Morning, thank you.
Morning.
Good morning.
Chair, the witness this morning is Dr. Uzarali.
Thank you.
If you repeat after me, I swear by Allah
I swear by Allah
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank
it's okay
you.
if I just roll up my sleeves, is that
Of
all right?
course. Can you give your full name to the inquiry, please?
Dr. Hussain Uzarali.
Doctor, you have completed 3 witness statements for the inquiry. The first is at DRO 501, the second on behalf of Dr. PA Limited at DRO 502, and the third at DRO 503. And Chair, I'd ask that those statements be adduced in full, please.
Indeed, thank you.
What that means, Doctor, is that those statements stand as your evidence to the inquiry, so I don't need to ask you about every single line in them. But I'm going to cover various topics with you. The first is your background. What qualifications do you hold?
So I've got an MBCHB, which is a medical degree. I've got a MRCPCH, which is a member of the Royal College of Paediatrics and Child Health. MRCGP, which is a membership for general practice. I've got a BSc Intercal 2-1 from UCL for medical microbiology, and various diplomas. Do you want me to go through all of them?
No, that's fine, thank you. You started work at Brook House when exactly?
You'll have to probably tell me. It's probably 6-7 years ago, I think now.
So I think you started in immigration healthcare in 2013 and at the Gatwick IRCs in December 2014. Does that sound about right?
That sounds about right.
How did you come to work at Brook House?
At Brook House, very briefly, I'd been working at Harmondsworth at Heathrow Immigration Centre. And they had a change of provider, and I'd been working in that sector. It was work that I felt that I could make a difference, and I felt I understood. So I applied to work over there. I worked there as a locum under Saxon Brook.
So you first started as a locum at Brook House.
Yes.
When did that change?
Again, you'd probably have to tell me the exact dates. It was probably a year. I would have thought a year and a half in, around that.
And so you currently work there as a subcontractor to provide GP services, is that right?
That's correct.
And the subcontracted company is Dr. PA Limited.
Yes.
And you're a co-director of that company and founder
Yes.
with Dr. Saeed Chowdhury, who we're hearing from later today, is that right? And is it just the two of you?
It is.
Do you currently work anywhere else other than Brook House?
Yep. A combination of HMPs, secure environments across the country. Do you want me to tell all the places?
You could
So
give an
HMP
example.
Onley, HMP Little Hay, HMP Whitemoor, HMP Feltham, IRC Yarlswood. Oh God, I'm forgetting this. Peterborough, HMP Peterborough. There's a couple more that just for the sake of here that I've.
Thank you. In paragraph 2 of your second witness statement, and there should be a bundle there if you of documents. It's at tab 2 if you need to refer to it. You say that you were involved in providing training and supervision to GPs at Brook House. But then at paragraph 7 of the same statement, which is on page 2, you say Dr. PA Limited does not run either currently in the last 12 months or in 2017 any training courses for the benefit of Brook House healthcare staff. What is the position in relation to training of GPs at Brook House?
So we don't run formal courses or training. We provide an induction and an ongoing support, which is itself a training, but it wouldn't be formalised as a course. It wouldn't be a certificate at the end of it. But we support our GPs in many ways because when I first started in immigration, there was no support or guidance, and it's a very complicated, as you can see from here, very complicated area to navigate your way through. And we want to attract the right GPs, and that involves supporting them sort of emotionally and educationally.
And how many GPs currently work at Brook House? Yourself and Dr. Chowdhury?
And I would say there's probably about 4-5 GPs who are regular, and then we have certain GPs that have sort of weekends here and there. So maybe about 8 or 9.
And is that all through Dr. PA Limited?
Are all those individuals through Dr. PA?
Yeah.
Yes, they are.
Thinking about the role of a GP working in an immigration removal centre, your role is to provide healthcare services to the detained people who are patients there. You would have the same duties as a GP towards your patients as you would in the community, is that right?
Yes.
And those duties and standards are set out in general by your professional regulatory body, the General Medical Council, the GMC, is that right? Sorry, you have to answer for the transcript.
Yeah.
Thank you. So some of those types of duties and standards towards your patients are to make them your first concern, to put your patients' needs as a priority. Is that right?
I think are you quoting particularly the GMC Code of Ethics, and is that what you're referring to?
And the good medical practice.
Yeah. So yeah, we adhere to all of the codes
all of those
within.
standards.
Yes.
There's a requirement to keep your professional skills and knowledge up to date.
Absolutely.
Is that right? And there's a requirement to take prompt action if patient safety, dignity or comfort is being compromised.
Absolutely.
There's also a requirement to recognise and work within the limits of your competence. Is that right?
Correct.
And that would include taking steps to inform yourself and to gain training if you thought you needed it.
Yes.
Would that, in an immigration removal centre context, include familiarising yourself with the statutory regime, such as the detention centre rules under Rule 34, 35, 40 and 42?
I think the GMC guidance isn't particularly in reference to those guidance. If you're talking about it being in terms of should we understand the environment we work in, I think that would be expected.
And in relation to that particular statutory regime, because a medical practitioner, in other words, a GP, under those rules has certain roles and responsibilities, you'd be required to be familiar with them.
Yeah, I think any kind of safeguarding measures we would be involved in.
I want to look at some of those roles and responsibilities then under those rules under the statutory regime. In paragraph 74 of your first witness statement, you say the requirement for a Rule 35 assessment is undertaken at reception through focused questioning, example, are you a victim of torture, and remains a continual process throughout the stay in detention. Do you there mean Rule 34?
No. What? So do I?
Because you talk about a Rule 35 assessment undertaken at reception. Rule 34 is the rule that requires an assessment within 24 hours of arrival.
No. So I think if you're asking about, I don't know how that was sort of put together, but essentially what I would have been saying is that the Rule 35, so if someone's a victim of torture in the screening process, that would be identified at reception.
And is that the screening done by a nurse?
That's the screening that would be done by a nurse. And then the continuation of understanding vulnerability, that would be an ongoing process throughout their stay.
You say at paragraph 42 of your first witness statement that new residents are offered appointments to see a GP. Is that at reception?
Yes, that would be.
So an appointment is offered, and you say all new residents are offered an appointment within the time frame stipulated above, which is 24 hours. Is that right?
That's my understanding, yes.
In 2017, were those appointments with a GP under Rule 34 being carried out within 24 hours?
I believe so, yes, they were.
Those appointments we've heard from Sandra Calver were approximately 5 minutes long. Is that your recollection as well?
I think the 5 minute that you refers to is on system 1. You have to book a time slot in order to put the names in. So I don't think the 5 minute period necessarily reflects like it's a fixed number that at that 5 minutes you would say it would usher people out the door. There would be people that would need less because they might not want to be seen. They might have no medical issues that they disclose. There might be no ongoing referrals or acute issues. For those that required more time, we would spend more time with them. But I think the 5 minute thing is what they have to factor in a period of time during the day that we would be able to see the patients. So I think that's probably what it denotes.
Was that appointment within the first 24 hours for a full physical and mental state examination?
I think that whether something is for a full mental health or physical health examination is perhaps a public conception of how we deal with issues. You couldn't possibly do a full mental health examination. A full mental health, you could spend any duration of time. You could spend an hour, an hour and a half with a patient. I think we did what, and I think Dr. Hard referred to it, it's almost like a triage. It's understanding their healthcare needs at that first appointment.
If perhaps we can have on screen Rule 34, it's at CJS 006120, please, and it's page 11. Thank you. So this is Rule 34 of the Detention Centre rules, and at subsection 1 it says every detained person shall be given a physical and mental examination by the medical practitioner.
So is that 34.1? Are you at? Which one are you at?
34.1.
34.1.
Medical examination upon admission and thereafter. Every detained person shall be given a physical and mental examination by the medical practitioner or another registered medical practitioner in accordance with Rules 33.7 or 10 within 24 hours of his admission to the detention centre. Do you see that?
I do see that, yeah.
So what Rule 34 requires is a physical and mental state examination of every single detained person within 24 hours of their arrival. Would you agree?
Again, it depends on, it says physical and mental health examination, but it doesn't say the intensity of that examination. So when you meet patients, you are doing a broad head-to-toe examination discussion with the patient, but that doesn't necessarily, there's no time frame. I think it would be irresponsible to give a time frame to that.
No, but it does require a physical and mental examination of every detainee within 24 hours of admission, doesn't it?
I don't wish to be contentious, but it does, again, depend on the level of the physical examination. You wouldn't expect to do a full cardiovascular examination or a full respiratory examination in, that alone you could take 10 minutes just doing a physical. So physical's quite, it's not detailed enough on there to really guide clinicians. I don't know what time frame the chair would feel would be appropriate. If you were to really say what would be an appropriate time frame to examine a patient and conduct that examination as stipulated.
Well, what I'm asking you about is the requirement of the rule. The rule requires a physical and mental examination by the medical practitioner within 24 hours of his admission to the detention centre. That's right from the wording of the rule, isn't it?
Yeah, and it also, yes, no, it does.
And that's of every detained person, not simply if there's a need identified or the nurse requests it.
And it also doesn't say offered as well, does it? So I suppose whether they want it or not, it should be given.
Detainees can refuse to be examined, can refuse this appointment, can't they?
I believe that's the right of, it'd be consensual.
Yes, they need to provide their consent.
Yes, absolutely.
When detainees refused to be examined or refused this appointment, do you know if it was explained to them what the purpose of the Rule 34 assessment was?
I wouldn't know. That would have happened before I got there.
Because unless they understood the purpose of the Rule 34 assessment, that's the mechanism to assess whether a Rule 35 report is necessary, and that feeds into decisions about whether they should be detained at all, it wouldn't be an informed refusal, would it?
I don't think the initial physical and mental health examination which you referred to was its sole priority was to identify whether they should be detained or not. It might lead on to a Rule 35, and there would be other aspects that might during their stay. But I'm not sure.
So
It almost suggests that you say one leads to the other, and I'm not sure I agree
did
with
you
that.
think that a Rule 34 assessment shouldn't lead to a Rule 35 report?
No, I'm saying it doesn't automatically lead to a Rule 35. Rule 35 assessment can happen at any point,
Yes, but
any encounter.
one of the purposes of Rule 34 is to ensure that within 24 hours of a detained person arriving at an IRC, they have a physical and mental examination in order to determine whether they need a Rule 35 report, isn't it?
Is
That's
that what
the
it says?
purpose
Does
of
it
the
say
rule.
that? Sorry, you're saying that it leads on to. That's the bit.
I'm asking you what your understanding of what the rules required was. Did you think that a Rule 35 report could be completed, if appropriate, as a result of the Rule 34 assessment?
I agree with that statement, absolutely. That a physical, an initial contact with a clinician may then trigger it, but I don't think the Rule 34 was in order to lead to a Rule 30. That's the point I'm trying to make.
But if something had been discovered in that physical and mental examination of the detainee within 24 hours of admission to the detention centre that meant it was appropriate to complete a Rule 35 report, it should be completed, shouldn't it?
No, and I completely agree with that statement.
It's not that there needs to be a separate assessment under Rule 35 at a later time in order to complete a Rule 35 report. It can flow directly from this appointment.
It can flow from any encounter with a patient.
Because otherwise, if there were disclosures or matters arising out of that appointment, out of a physical and mental examination, that meant that a Rule 35 report was appropriate, was necessary, and one wasn't being completed, then the safeguards are failing at that initial stage, aren't they?
If something was identified and a Rule 35 was indicated, absolutely, and it wasn't completed, that would be a failure. I completely agree with that.
Were these Rule 34 assessments leading to the completion of Rule 35 reports in 2017? Is that what you were doing?
Is that so? I think it's difficult because I think firstly I'd have to go through all the Rule 35s, but I think the broad statement you're sort of referring to is the point of the rule of the new arrivals appointment, which was the Rule 34, was to allow them access to a GP, and in that initial assessment, and I sort of focus on the fact that it's an initial assessment, if something was identified, we would have certainly considered it. From memory, would that often be the case? No, I don't think so. That we would then complete, and I guess you mean which Rule 35 you're talking, you're 1, 2 or 3?
Well, it could be any of them, couldn't it?
Yeah, no, it could be. So was it complete? And are you asking whether it was completed at the time of the initial consult?
Well, as a result of the assessment,
Would it lead
that's
on to an
required.
appointment? That's what you're asking.
I'm asking you whether in 2017, where something was indicated from that physical and mental examination under Rule 34 that happens within 24 hours of a detainee arriving in the centre, whether as a result of that appointment, Rule 35 reports were routinely being done immediately.
I think if we identified anything in the initial consult, then a Rule 35 would be done.
Because the Rule 34 assessment, the physical and mental examination, is not it's important for picking up clinical concerns that might need treatment, isn't it? Either physical or mental
The Rule
health.
34?
Yes.
Yes.
But it's also, as we've been through, to pick up potential vulnerabilities that might be relevant to a Rule 35 report.
Absolutely, I think yes.
So, and again, it's important because these are safeguards for detained persons who are vulnerable and at risk in detention, for the Home Office to consider whether they should be detained at all, isn't it?
That's the purpose of the Rule 35, as far as you mentioned, yes.
But again, the two rules work together, don't they? Because it's important that those vulnerabilities are considered at the outset of their detention, isn't it?
No, I completely agree with that, and I would argue that it would almost be more sensible to consider them before the detention was even in place.
Yes. Perhaps we can look at a couple of examples. In relation to D2033, can I have on screen, please, DL 5045. And if we can just, there we go. This person arrived into Brook House on the 4th of April, we can see, and was screened by Ms. Wade, the healthcare assistant. We can see there, if we scroll down slightly, he disclosed a history of torture. He claimed to be a victim of torture. And if we go over the page to DL, I think it's DL 5046, they're separate documents. He was due to see a doctor on E-wing the next day. That appointment didn't happen within 24 hours, and the first time he in fact saw a doctor was Dr. Chowdhury on the 8th of April. And there's, if we scroll down slightly, and I think the next page, DL, there we go, and up to the top, please. Thank you. If we look at Dr. Chowdhury's entry on the 8th of April, there doesn't seem to have been an examination of any kind there, does there? One's not noted.
No, there doesn't appear to be an entry into System 1 there, no.
So this is an example of someone in the screening process disclosing that he's been a victim of torture. That should lead to consideration of a Rule 35(3) report, shouldn't it?
Was it booked? I don't know.
Well, it was noted that he was due to see a doctor on Ewing the next day. That appointment didn't happen. It should have done, shouldn't it?
But was he booked to Rule 35 appointment?
It was noted that he was due to see the doctor on Ewing the next day.
But
that would be within the 24-hour period for the Rule 34 assessment, wouldn't it?
Yeah, so you're talking about the Rule 34, sorry. Yes. Yeah, so that would be within a 24-hour period, and if he was due to see someone, he should have seen someone there. Yeah.
And if he didn't, then the Rule 34 wasn't complied with.
No, obviously wasn't, no.
He disclosed that he'd been a victim of torture.
Correct. That's what it says, yeah.
And if he'd had his Rule 34 assessment, the GP would have noted that because it's noted in the medical record from the day before.
What would normally happen is that if someone disclosed that they had been a victim of torture, then that would prompt the nurse to book a Rule 35 appointment. So you wouldn't be doing the Rule 35 unless it was within the fixed designated appointment.
But you've agreed with me that Rule 35 reports, if appropriate, can flow from the Rule 34 assessment.
Correct.
He disclosed that he was a victim of torture. That should prompt a Rule 35(3) report, shouldn't it? At least an assessment.
Yes, that's why I asked you whether he'd been booked an appointment. So that would be, he wouldn't necessarily, when I say the Rule 35 will flow from the Rule 34 or a contact, they would be booked an appointment. It wouldn't be the next day that the Rule 35 would be Rule 35(3) would be done.
So is it your evidence that even if a disclosure had been made in the screening process with the nurse, and he had been due to have his Rule 34 assessment within 24 hours, as every detainee requires, that having disclosed that he was a victim of torture, he would still need to have a separate Rule 35 assessment?
Correct.
In order to have a Rule 35(3) report considered?
Yes.
Why is that extra step necessary?
I think because there's a designated time within there's only a certain limitation in the amount of time that a GP would be working in a given time. So and you need a certain period of time to complete a Rule 35. So they designate at least 45 minutes. You might need an interpreter. I think he was Afghani. Did I see before?
Yes.
And so he most likely need an interpreter. And you'd have to be in a clinic room. You wouldn't conduct the Rule 35 in E-wing. It would be completely inappropriate to do so. So they would be booked an appointment. And in order to facilitate the rest of the delivery of healthcare from the GP point of view, where you have new arrivals, you've got the Rule 34s, you've got the Rule, you've got one Rule 35, and you've got clinic time. You couldn't possibly just focus on Rule 35. Now, if there were, and I think in some immigration centres where you have very low populations, then you might well be able to identify, and you might not have as many individuals that claim to be victims of torture, and you could do it on the day, and that would be the ideal. And I think at one point the Rule 35, you had to complete, if you had concerns of torture, my understanding was that within sort of 24, 48 hours, if you identify that, it should be highlighted. Realistically, and I can't speak for the exact time frame because I don't have the data for that. At one point there was a 2, 3, 4 week wait to get a Rule 35. And I suppose the next question you might ask is, do I feel that's an appropriate length of time to wait if you feel someone is a victim of torture and or their mental health is deteriorating? I don't think it's an appropriate amount of time. But in order to facilitate, we weren't there just completing Rule 35s. We were there delivering healthcare as a GP.
So it was a resource issue?
I think if you set the standard as being you, and I think you are alluding to that if you identify a vulnerability, which may be injuriously to the health of the individual. If you are identifying that, then that information should be passed on soon. Now, I don't know if at that time whether that information, as in claims to be a victim of torture, was passed on through a Part C, which was also a much more responsive and less detailed, but at least it would identify that to the Home Office in the interim period. I can't speak for that time frame because I can't recall when, and I don't know whether Part C was done in this case, but that would normally. But I see the ACDT was opened from the notes, just the top part of it.
But the ACDT didn't lead to completion of a Rule 35 report in this case. Should it have done?
Should an ACDT in this... I mean, I only have the information that you've just put in front of me. So should an ACDT always end up in the Rule 35, or should it have done it in this case? Which one is it? Or both? Both. No, fair enough. I think the difficulty here is the Rule 35, and this is much broader, and this may be something that you come to. The Rule 35 was a means of communication to the Home Office to identify vulnerability. And being quite a weighty document in terms of completion and time required, it wasn't always the most reactive and dynamic route. So an ACDT would have been open. I would have expected a Part C in the Home Office to be informed in the interim. Now, if you were to link that up and say, well, that it should have left to a Rule 35, I think at the Rule 35 appointment, so in the context of practically what would have been happening, and I can't speak individually for this case because I don't have all the information, but what would have, by the time a Rule 35 was completed, and I don't know again when it was or if it was, I would hope it was.
It wasn't. It should have been, shouldn't it?
Absolutely. No, if someone's been a victim of torture, if someone has claimed to be a victim of torture, we would expect an appointment to be booked. And as a GP, we don't book the appointments for that unless they were to disclose that during a consultation with us, then we would book it. But if it's identified at reception, as a GP, we would not know that information about that disclosure because we'd not be screening every single person's notes to see what every clinician, if you've got 500 patients, you can't know what every entry and every note is. But I would expect it to be a Rule 35. The issue of resources is not something I work within the facility of, what you give me and what I can do.
In relation to the ACDT in this case, this is someone who was a young man, he was possibly a minor, he was moved to E-wing because there was a concern he was under 18. He had a history of suicide attempts, and he appeared to be in low mood and saying that he needed medication, had been previously on medication for depression. All of those are factors that relate to vulnerability, aren't they?
I think all of those, so being young, having a history of being on medication, being a victim of torture, are indicators of vulnerability. To vulnerability in general, we're talking about.
And those are factors which it's relevant for the Home Office to consider, for example, under Rule 35(1), as to whether he should be detained at all at the outset of his detention, aren't they?
I don't know what communication and what awareness the Home Office would have had. So, I mean, maybe.
But they
would they be aware of his?
They have to be provided with the information in order to consider vulnerabilities when making detention decisions. The mechanism to do that is Rule 35, isn't it?
One of the mechanisms.
But Rule 35 is the mechanism which prompts a review of detention, isn't it? Part C doesn't.
No, my experience is that in passing any medical information to the Home Office, that should review. My experience is that it has reviewed of detention. That Rule 35 is one aspect of that. Now, I'm not saying that is my practical experience of communication with the Home Office.
In relation to D2033, he had appointments booked for him which he didn't attend. There was nothing in the records to indicate that the reasons for his non-attendance were followed up. Was it generally practiced to follow up non-attendance at medical appointments?
In relation to him, I think if it's in 2017, so it's difficult for me to comment on. In general, did people follow up? The GP would not necessarily himself or herself be following up. I can't speak for the practices of other people at the time. I would hope, especially where there was vulnerabilities, especially in this case, that was the issue. The other issue, just because you mentioned it, if there was consideration that he was underage, was that the reason he was in E-wing?
That's what it's
so
noted.
So one would assume, therefore, and also with the ACDC, that the Home Office would have been an age dispute. So the Home Office would have been aware of that.
How?
Well, it's an age dispute, so the communication is with the Home.
Who communicates with the Home Office, and how do they do it?
It would be healthcare.
Through Rule 35?
No, through any means. So the Part C is one means of communication. The Rule 35 is one means of communication. Emails, responses to Home Office inquiries. When it comes to an age dispute, there was a process in place, and I'm no means an authority in that process, but it was separate from healthcare in terms of the age dispute. And I believe the Home Office have mechanisms, only in terms of age dispute I'm talking about, they have mechanisms in place where they would have independent people coming in to do it. It wouldn't be, for example, my expertise to determine someone's age.
No.
So I assume the Home Office, the reason I mention that is, again, not disputing any of the points that you've made, is that I would expect the Home Office to be aware, and if not through a Part C, because Part C was the main means of communication from healthcare.
Was Part C being used instead of Rule 35?
No, because that would imply that we never did the Rule 35 if Part C was done. So I would say in addition to.
Does your contract stipulate that you must carry out Rule 34 assessments within 24 hours of detained person's arrival?
Dr. PA contract?
Yeah.
No.
Did you consider it part of your contractual duties to be undertaking Rule 34 assessments?
Well, it wasn't in the contract. So
no.
So if you're talking about contractual obligations, then one would not expect. But as from a GMC point of view, I suppose as a doctor, do I want to identify someone's vulnerability to make sure that the correct care is in place and management? Absolutely, and just as a human being, irrespective of being a doctor.
Do you take a salary as an employed GP of Dr. PA Limited?
Sorry, the reason for that question is, I just wonder what a salary has to do with my.
Well, when I ask the questions, you'll be able to answer them. Are you refusing to answer the question?
I don't see the relevance of my employment status.
We'll come to it.
Well, if you tell me the context of it.
Well, I'll ask you the questions and you can decide whether to answer them. Do you take a salary as a director of Dr. PA Limited?
I have an income from Dr. PA.
The value of the contractual provision of primary care services in Brook House through Dr. PA is substantial, is it?
Again, I'm not sure I really want to answer that question.
Do you consider that there's a that the financial incentive arising out of the contract causes any conflict with the interests of your patients and your Rule 34 and 35 obligations?
No.
What steps have you taken to safeguard against such a conflict and to ensure your independence?
I think the very fact that I practice as a doctor and I had to adhere to GMC guidance and experience and ethical practice, that alone is enough of an incentive, irrespective of how much I earn. If I was on a lower wage or a higher wage, I would still consider the care of my patients above anything else.
Yes, you'd accept that your patients' interests come before your financial interests.
Absolutely.
As a director, though, of a company, you have certain duties under the Companies Act, don't you, towards the company, for example, to promote the success of the company?
I think I want to have a successful company, if that's what you're...
Do you consider that there's any conflict between your duties as a director to the company with your duties as a GP to your patients?
Not at all. In fact, I think if I do my job properly, people will want to employ me. And doing my job properly means delivering good care and making sure that no one suffers under my care. And I wouldn't want that to be. I mean, you're a doctor is a vocation as well as, it's something that I've always wanted to be, and I ensure that I deliver good care on a day-to-day basis.
Did you consider that any damage to your relationship with the Home Office would risk renewal of your contract?
No, I've never considered that, which is why we challenge the Home Office. I mean, what I do feel is that in order for I do not want to put for example, we have our number one priorities, our patients, and the delivery of care, and making sure that the outcomes for our patients are good. So if I can do that and improve the system, which we have attempted to do, and if that means challenging the Home Office, we will do that, because that works. That's in our interests.
Did you consider there was any risk of damage to that relationship with the Home Office if you sometimes put the best interests of your patient over and above the Home Office's interests?
No, there was never any indication. I mean, we as an individual, I've always challenged the Home Office to improve systems, and if I feel and I identify, and again, you might come to this. So I'm sorry if I make the point before you have. In terms of the Rule 35, off the back, for no sort of financial incentive, I was emailing the Home Office independently of my contractor, because I'm a subcontractor. I don't have a direct relationship with the Home Office. I'm subcontractor to, at the time, it would have been G4S. So actually what I wanted to do is I would email and try and find, but the Home Office is a huge behemoth of, and it's faceless in some respects, because you're never sure who can make a decision. And I managed to organise a meeting and do a presentation to them with my colleague Dr. Chowdhury, and myself and Saeed went there and presented and explained to them the challenges in relation to the Rule 35 and how it could be improved. And that's not to make it easier for ourselves, but for it to be more effective as a safeguarding measure, rather than what was currently being the process that was running as it was. But it's illegal, it's a document that is bigger than me, and unfortunately, although we eventually got people to listen, after that consultation, I think it was at the same time the adults at risk policy was being developed, we heard nothing, and we tried to follow up on it again and again and again. I think I have it on my diary every 6 months to email them and say, look, is there any improvement? Can we implement changes that would facilitate changes that were recommended in the short report? Because that's what we felt was the right thing to do.
Did you consider that certifying someone as not fit to detain or not fit to fly might damage your relationship with
Absolutely
the Home Office?
not at all, because it was an individual case, and we were there as patient advocates in terms of if we felt someone was not fit to fly or not fit for detention. And the irony was, I suppose, because you mentioned about not fit to fly or not fit for detention, is that there have been cases where we've said someone's not fit for detention, but they're not fit for release, because actually their care, they're so precarious with their mental health that we have responsibility to make sure that releasing them in the middle of that care might be dangerous. It's not a common practice.
So were people's detention sometimes continued when it was suggested they should be released? In order to give them
I suppose
care
if the answer, so if the question, and I'm paraphrasing it so that, and you please tell me if I've taken it out of turn, if it were to be the case, did all my Rule 35s where I said not fit for detention end up in release? No, they didn't always end up in release.
What was the reason for that?
It would be individual. I wouldn't be able to say. There was not a trend that I can identify.
Did you consider that sometimes your healthcare assessments were being overruled by the Home Office and people were being detained when they shouldn't be?
In the most, or individually? So as a trend?
At all.
As a trend, I felt I had developed a relatively good relationship with the Home Office that where I had very, very strong convictions that not only was their health injuriously affected by prolonged detention, that we were, I could evidence it, which was often the which carried the most weight, that we saw, and where we felt we couldn't manage them effectively within detention. I would say that the Home Office were responsive in those cases. I'm talking where I had very, very strong convictions, and obviously there'll be different levels of conviction because there's likely to get worse, and then there's the ones that are getting worse, and where we can justify it. And the Home Office, in that respect, that's where the lines are. That's where the Rule 35 is almost a static tool. It's a blunt tool, where a Part C would be, if we did a Rule 35 and said this person is potentially could get worse, the next, it's almost like, they've had a Rule 35, because actually to get another one done, it might be that their mental health changed 3 days later. Then do you do a Rule 35 then when it gets worse, or if their mental health improves, which can happen, and frequently does happen in the initial phases, if they start to get better, do you retract your statement that they were not fit for detention, but they are now? Because these things are dynamic.
Yes. In looking at Rule 35 a bit further then, you say in your statement that you were, at the time and are now quite experienced in undertaking the Rule 35 assessment, having been working in an IRC for more than 2 years prior to 2017.
Yes.
Would you say that in 2017 you had a good understanding of the rule?
I think I would. No, I do feel that I had a good understanding. I think I have a better understanding now.
In 2019, I think it was, during the course of an independent investigation by Dr. Linsell, you spoke to him, I think, about Rule 35. Do you remember that?
Yeah, I do remember the encounter, yeah.
And in speaking to Dr. Linsell, you described Rule 35 reports for being done for reasons of torture, medical health, or mental health. Is that your understanding of the three limbs of the rule?
That is my summary to Dr. Linsell, who didn't understand had no experience of Rule 35. I'm not saying those are not the different branches. There are three, and there's one suicidal intention. I think that's what you're referring to, isn't it?
Yeah, so that's not quite right, is it, as a description?
No, but is there a summary to someone that does have no experience? It would be a fair description to say we consider those three aspects.
In terms of the training you've spoken about that you and Dr. Chowdhury are involved in with new GPs at Brook House, and you talked about the support you give them through Dr. PA and through your work in Brook House. Does that training cover the adults at risk policy, Rule 35 and ACDTs?
It would involve, yes, it would involve all of the above.
We know that you attended some.
Although, sorry, can I just say, we don't. The adults at risk policy is the definitions that is ultimately. The categories are Home Office driven. We don't define who is an adult at risk, if you will. Was in which category within that? Just so that context.
We know that you received Rule 35 training in January. I think 2018 from NHS England. Had you received any training yourself on Rule 35 prior to 2017?
There were two, and I was trying to work out when I was asked when there were two training sessions. I can't remember. One of them was I think Sandra Calver has mentioned one of them, and there was one predating one. So before Dr. Chowdhury would have done it, there was one prior to that I attended.
And who provided that training?
That was in the Home Office buildings opposite Downing Street. I remember being there.
Could we perhaps look at a document on screen, please? HOM 002581. I just want to see if you recognise this as being the type of training you received prior to 2017. We see that it's dated October 2015. It's a Home Office document, and it's effectively a slideshow, a PowerPoint presentation. That's the first page. If we go to the second page, please. Those are some people listed who relate to the background and the purpose of Rule 35. If we carry on to page 3, please. The rule is set out. And page 4, the different detention service, the relevant detention services order is mentioned.
Can I just contextualise something, if that's okay? So there was a time when we used to do Rule 35, and the document actually had 1, 2, and 3 on the same document, and we would tick which bits.
Yes.
So it wasn't 3 separate documents. So because I don't think that was in here. But when I first started doing it, I can't remember when it changed. It was all on one document.
Yes, and then it changed to be that the 3 limbs of the rule. No, there were 3 separate templates. That's right.
Yes, that's exactly right. Thank you.
If we go on to page 5, please. The purpose of the rule is set out there to ensure that particularly vulnerable detainees are brought to the attention of Home Office caseworkers with direct responsibility for authorising, maintaining and reviewing detention. And then on to page 6. What's that, page 6? Next page. The Home Office policy is set out that persons with independent evidence of torture are normally regarded as unsuitable for detention other than in very exceptional circumstances. Was that your understanding at the time?
It was, and the difficulty with that is, what does independent evidence of torture mean?
Page 7, please. The definition of torture at the time... This was the
old one, wasn't it?
...was provided. Yeah. And at page 8, please. And then the remaining slides go on to address what, as the question says at the top there, Home Office caseworkers were looking for in a Rule 35.3 report. The training doesn't address any further the other 2 limbs of the rule. Do you recall if that was the case in your training prior to 2017, that the focus was very much on Rule 35.3?
Absolutely. And I think that was somewhat the case of... that the majority of at the time was to do with victims of torture. That was the highlight of that, and they were fully aware, and it was discussed, although not documented. And I think Sandra Calver was at some. I can't remember if she was at one of the teachings or not. all the clinicians raised the multiple points and discussed it, and it was quite heated. Aside from this talk, this was one part of a slideshow that was been and gone, and everyone acknowledged it, but it was the platform for all the clinicians to discuss and say, well, we do Rule 35s. You're telling us now that, one, they're all going to be on separate documents. Is that not going to be duplication of information? And how useful is it? And secondly, according to your information, what we all felt at the time was that it suggested that every ACDT should be a Rule 35. That was, it didn't say that explicitly, but it implied it. And you might say, well, it says it explicitly. But we all felt that actually, how was that going to be? How was that practically implementable from what this definition was? And we were given no information as to how to implement it. It was simply, this was developed, this is what's going to happen, and it was left there. And everyone, I would say everyone, all the clinicians that fill out these forms had the same reservations and concerns, and nothing was changed. So people developed their practices, which was broadly consistent across all the immigration centres.
So when you were providing training and supporting GPs, new GPs in Brook House, as you've said you did, what did you consider particularly qualified you to deliver that training?
Having attended the only training courses that were there, and having had experience of having written Rule 35s for, at the time, say 5, 6 years, depending on which point you take it at, so 6, 7 years of, and then looking at and seeing the response from the Home Office where there wasn't sufficient detail, or where other questions they might need, and that has evolved so that now we would look at, and a lot of this focused around what to write in Section 6 of the Victims of Torture, if you were doing a Rule 35 Part 3, is how I can explain to a GP what kind of information is it appropriate and right to put into that, for it to be useful for the eyes of a non-clinician on the receiving end reading it, and for you to express your concerns.
And so you considered yourself to be competent from your training and your experience to deliver training to other GPs?
And that's why, so the training, it wouldn't be that I do feel I am competent to write a report for a Rule 35, I do, yes.
And to train other GPs to do so?
I did. I would, yes, I do.
But if you've talked about the concerns and the problems you were raising with the Home Office about the training and about the system itself, would you accept that if the training you were given was inadequate, you were likely to be if the training you received was inadequate, you were likely to be inadequately training GPs as a consequence?
I don't accept that, and I wouldn't. I think the danger of saying, well, I'm not adequately trained, therefore I will leave the GP to do it just on, from to almost just find their own feet, I think would be more negligent, and actually would leave that GP a little bit. They would ask me, what would you do? And so what I did provide is I would find the Rule 35s that I felt were sufficiently detailed, so that it was about writing the right amount of information in there. I don't mean not enough. I mean making sure that they conveyed in that Rule 35 important details. And I would show them, I would reference evidence of good Rule 35. So, for example, we would show them where there was a medical, where we couldn't offer good, someone's health was deteriorating either mentally or physically. This is an example. You don't have to copy it. We're giving you examples of where this is a good amount of detail, and the outcome was a positive outcome for the patient. So that in that respect, I wasn't didactically with a PowerPoint presentation saying do as I do. I'm saying these are examples, and this is the DSO, and then we.
If we look at the rule, then can we have CJS 006120 at page 11 on screen, please? And thank you. Rule 35 is there in the middle of the screen. At subsection 1, it says the medical practitioner shall report to the manager on the case of any detained person whose health is likely to be injuriously affected by continued detention or any conditions of detention. And subsection 2, as you've referred to, is where a report's made in the case of any detained person the medical practitioner suspects of having suicidal intentions. You understood that those two subsections of the rule at the time in 2017.
So yes. 'Cause
Thank you. In relation to the subsection 1, it's likely to be injuriously affected by continued detention, isn't it? Likelihood being quite a low threshold.
I don't know if that's a low threshold. Likely is quite...
It doesn't require harm actually to have been caused.
No, it doesn't require harm. It's likely.
And Rule 35(2) requires a doctor to complete a report where he or she has suspicions of suicidal intentions, doesn't it? Again, suspicion being quite a low threshold.
I don't think they're low thresholds. I think they're reasonable thresholds.
But it doesn't require, for example, an actual suicide attempt, for example.
No, it wouldn't require it, but it would need you to actually have someone to say in many ways that they either display or say they have a suicidal intention, which itself is not a low threshold because they've already reached their mental health has deteriorated to the degree where they're saying it.
If we look at the interaction then with ACDT, you say in your statement that when an ACDT was open, GPs would complete the form and also discuss with the centre staff, and healthcare staff, including GPs, would also communicate concerns to the Home Office through Rule 35 or Part C, which you've
and that's,
discussed.
So that's if the GP were opening the Act. Obviously, the Act doesn't have to be opened by a GP, in which case the GP wouldn't be in the first part of that statement.
Who does a Part C go to at the Home Office?
If I'm honest, I don't know where all the communication goes through to the Home Office. It's not, even with the Rule 35, I wouldn't know the individual person or the caseworker that. So I'm not sure who responds to things at the Home Office.
Do you, if you as a GP were to open an ACDT, do you carry out a risk assessment of the detained person at that time?
So in order to open an ACDT, the first page needs to be completed. A risk assessment with regards to, if I can ask you that question, what do you mean a risk assessment?
Well, what assessment do you carry out when you
as part of the consultation,
open an ACDT?
As part of a consultation, if a patient were to, and as an example, if a patient were to say that I want to kill myself, as a flatline, I appreciate everything's slightly nuanced, but if they were to say that, then I would open up the orange booklet, which is ACT. I'll complete that. I'd mention what was said. You might not write a huge amount. The main thing was at that point you're safeguarding. It's a document then to pull the different teams into place. Mental health team, security would be called because they might be actively just saying they had suicidal intent.
Was your role in opening an ACDT and recording that information to give clinical advice on the management of risk of self-harm or suicide?
No.
Self-harm is...
That doesn't mean that we wouldn't, but the Acts document, that purpose was to bring the relevance, a coordinated approach. We have a similar system in HMPs.
It's a custodial management of risk system.
But also bringing in the mental health team. So it does coordinate care, but the document itself would not be where you might have Act reviews and it's coordinated, and it's a more... It gives a structure and a framework to work to, but in terms of our individual care as the GP, we wouldn't be involved in the Act process and the reviews, but we would be liaising with the mental health team at MDTs or ad hoc or when required if we were dealing with it, and we've been involved in that side.
And where an ACDT is opened for reasons of self-harm or risk of self-harm, is an initial assessment made of physical health mental state, safeguarding concerns, and social circumstances, and the risks of repetition of suicide.
I would imagine, and I would expect, that a mental health team would be reviewing, and those considerations you mentioned would come into play.
Would that be your role?
No, it wouldn't be my individual role. I wouldn't be involved in every ACDT. I would be involved if the mental health team asked me to be involved.
What's the threshold for opening an ACDT?
The threshold. So when you open the Act, the first page has. I think you may even have reference to it on one of your systems or in this big leaflet folder. So there's a number of bits that you would tick. So one of those, and I can't remember them off the top of my head, but one of them would be suicidal intention declared, or along those lines. But you would tick the box which would fit why an Act should be.
Is there an assessment of all those other things, though? Physical health, mental state, safeguarding concerns, risks of repetition, social circumstances?
Because I'm not, after that first page, in terms of documentation, I'm not involved in that, directly involved. I wouldn't want to say is there. I would assume that the mental health team would be doing all of those things. I would expect that to be the case.
If you were opening the ACDT, would you do it, though?
No, so we would open it. So you open it often from a GP in an acute situation where actually the first thing you need to do is you've got the risk of a patient expressing a desire to kill themselves. So at that point, you're dealing with an acute problem. So the long-term management is important, but in that acute setting, is this the right environment? By environment, I mean you're in the clinical room. Are they going to try and kill themselves? If I let them leave my room, as an example, this is not for all ACDTs, but if I'm going to open an Act, it's because leaving me just... if they say I'm going to leave this room, I'm going to kill myself, I have a genuine concern of the safeguarding aspect for my patient. I don't feel safe letting them leave, so the officer would come and then they would manage that initial risk, and then there'll be review processes. And the Act is not linear. I think there's multiple routes in terms of reviews from the centre staff and things like that.
In terms of the threshold for opening it, a suspicion that there are risks of suicide clearly meets that threshold, doesn't it?
Yeah, no, absolutely.
And a suicide attempt would certainly meet the threshold.
I would agree.
If someone has been placed on an ACDT on a constant watch, on constant observations, that indicates a high risk of suicide, doesn't it?
Yeah, it makes sense. Yeah.
And you say that when an ACDT is opened, healthcare, including a GP, would communicate concerns to the Home Office through Rule 35 if the threshold is met. Someone on a constant watch indicating a high risk of suicide would meet the threshold for a Rule 35-2 report, wouldn't they?
So, and that was not the dilemma, but that was one of the challenges of that document that was highlighted by all immigration doctors across the country, was that how do you manage that? And given that there are lots of ACDTs open, and given the fluctuating nature of mental health, where someone may say one thing and then 2 days later they may feel better about it because it's situational.
But if someone's been placed on a constant watch, that indicates a high risk of suicide. A high risk of suicide would meet the criteria for suspicions of suicidal intentions under Rule 35-2, wouldn't it?
It would meet that criteria.
And so in those circumstances, a Rule 35-2 should be completed, shouldn't it, at that time?
It should definitely. So according to the Rule 35 guidance, as you said, it would fit that criteria. But with the Rule 35, as far as most clinicians, the main thing would be communicating that safeguarding need to the Home Office, because that's...
But the mechanism to do that in this particular circumstance, where someone is at a high risk of suicide,
so the Rule
is
35,
Rule 35 too.
So that and a Part C would be indicated.
In fact, we know that in 2017, there were no Rule 35-2 reports completed at Brook House. Why is that?
I think because the mechanism of communication would have been through the Part C.
But
I appreciate what you're saying, that the Rule 35 was an avenue and it fits the criteria for it.
Well, it was a requirement, wasn't it, under the rules?
According to the rules, as you say, yes.
It was your responsibility to apply the rules as a GP working in Brook House.
Yes, and I think the difficulty here is the rules were made which were not practically implementable.
So you weren't applying them.
We were communicating, so we used it as a safeguarding measure.
But there were no Rule 35.2 reports in 2017. In fact, there were none in 2016, 2018 and 2019 either. You weren't applying the Rule 35.2 safeguards, were you?
Well, if there were none applied, that's the
Yes. There were a number of detainees during that time on constant watch, though, weren't there?
I would imagine that there were, yes.
And there were certainly a large number of ACDTs open at the time. In 2017, we know that there were 195 new ACDTs opened and 248 open in total in 2017. That suggests there should have been significantly more Rule 35.1 reports and some, at least, Rule 35.2 reports, doesn't it?
It does.
What training have you received on ACDT?
I'm aware of the ACDT. Have I received formal training? No.
No. You, as you've told us, you don't have, as a GP, you don't have any role in managing the detained person on the ACDT, do you? Is it more of a nursing?
Do you mind if I just answer something from what you just asked? You mentioned about the Rule 35 and in the Rule 35, my understanding, and this is not to be contentious, it says for a medical practitioner to highlight to the manager that there is concern. Does it not? It's the duty of the health...
Shall report to the manager on the case of any detained person he suspects of having suicidal intentions.
So with that in mind, if the manager is already aware, yes, the document hasn't been completed, but the communication's been had. That's correct, is it not?
But isn't part of the safeguarding under the rule, including Rule 35.2, notifying the Home Office so that they can review detention?
So the point I'm not disputing the fact that the Rule 35 says, but the process is informing the manager who then will report to the Home Office in the form of that documentation. But I'm just making the point that the pathway, although the document hasn't been completed, and I'm not disputing that because you've got the evidence to say that, but the manager is already aware. And
so
then the manager can communicate that through a Part C2. Now, I'm not disputing that there weren't enough... The
only person who can complete a Rule 35.2 report is a GP, isn't it?
According to that, but the communication was...
And
I think
that's what goes to the Home Office to prompt a review of detention.
And the Part C as well would be going to the Home Office. But I agree.
Are you saying that you weren't completing Rule 35.2s in 2017 or indeed any of those years I mentioned because you were informing the manager of the centre by another means?
That the manager was aware and the Home Office would have been aware. If the Home Office were not aware, and I think I guess I make the point and that if the means of safeguarding is to inform the Home Office of things that may impact on an individual's detention, that is a safeguarding measure. Any information healthcare provide to the Home Office should prompt and have shown to, and the systems were in place showing that the Home Office are responding, that prompt release. The Rule 35 is not the only explicit document.
But it's the only one that requires the Home Office to review the detention decision, isn't it?
And I think
Part C doesn't require that.
I think any information that we pass, and we were communicating with the Home Office, and they would respond because it's more dynamic. So actually, the Rule 35s have a response time. I believe they have to respond within 24 to 48 hours. Correct? Is that right? Is that correct? Sorry.
Yes.
Yeah, they do. Okay. So actually, if you need a response quicker than that, if you feel someone's acutely suicidal, what mechanism is in place for the Home Office then to get that information quicker and respond quicker. We felt, and our experience practically, is that we were not working in. I think the implication of saying that we did not follow the rules of Rule 35 Part 2, the implication is that we were working in isolation and we did not have the best interests of our patients at hand. And that's the bit that I have issue with, because I don't feel that's the case, because we were passing that information, we were safeguarding in a way that was quicker. If you provided if there was resources that said to me, you have umpteen hours in a day, and you stay and complete the documents which are waiting, the thresholds are there, and the thresholds are there within the documents saying what could you do, are you able to manage this patient's care in detention, what's in place. Where we were providing the care, the Acdt document was there.
But the Acdt document is a management of risk of self-harm document, isn't it? It's not to provide therapeutic interventions or treatment.
No, and I'm not suggesting it is, but it's part of a therapeutic intervention to stop someone actually killing themselves. That's therapeutic in essence. It's stopping, it's managing that patient. But in addition to the mental health input.
Is your current practice to still use Part C as an alternative to Rule 35(2) reports?
I don't think
for the reasons you've given.
I don't think it's an alternative. I think
Are you completing Rule 35(2) reports presently in your practice?
I haven't completed a Rule 35(2).
At all?
No, not at all. I haven't completed a Rule 35(2). I've completed a number of ones, and the bulk of it is the Rule 35(3)s, due to the breadth of the definition of victim of torture and the pressure that has been put on to the clinicians to complete these documents. So,
just going back to ACDT, you mentioned ACDT reviews and that there would be mental health input into that. Was that through nursing staff?
yes.
You as a GP didn't have involvement in those reviews. Do you know why not?
I don't think the GP has to always be involved. Like, these are fully qualified mental health nurses, and they have direct access and work under the psychiatrists as well. So that's their input. So I don't necessarily see it would be good use of limited GP time to be at every review.
If you're not involved in the reviews themselves, are the results fed back to you?
Not of every review. However, we made implementable changes early on, and you'll forgive me that I don't know the exact dates. Myself and Dr. Chowdhury would implemented MDTs, where we could discuss cases where if someone wasn't on an ACDT, if someone had a complex need, and where we could identify patients whose health was deteriorating. And I appreciate you might say, well, it was after the event. If they're deteriorating, you've missed the boat. But I think thresholds are difficult to say, well, if someone is likely to be.
In those MDT meetings then, did you consider Rule 35(1) reports, or indeed Rule 35(2) reports if there was a suspicion of suicide?
Yeah, so an MDT, and although there was a time or a day that we would put for an MDT, if someone's needs were met, if someone's health, their physical or their mental health was of such concern, we wouldn't be waiting to an MDT a week later. That would absolutely be something we would be trying to institute medical intervention. And I think it's really important to say that whilst I can understand the focus is here on the Rule 35, that we were in the interim period, not twiddling our fingers, we were actually managing the patient's healthcare needs. And yes, detention review is important. Absolutely, I completely get that. But as a clinician, as a primary care clinician, working in an environment, we were delivering healthcare, and people were not neglected on the basis.
What do you consider then to be the relevance of Rules 35(1) and 2 in the context of a detained person being managed on an open ACDT?
So if we felt someone... So in the context, purely on that premise, we say, in that context, if someone was an ACDT, highlighting their acute suicidal risk, for example, or deteriorating mental health, that would be one indication, and a strong indication if it was to be either repeated ACDTs, which was opened and closed, because they can be opened and closed. It doesn't mean that the patient's 100% better. Or it was a prolonged one, an open ACDT, that during an MDT we would be discussing that, and it would be identifying that actually this is a very vulnerable individual. I think Sandra Calver instituted a pathway to give us some kind of clarity in how to implement and make sure the patients got the Rule 35 2 if they met a threshold. Now you might argue
But they weren't, were they? We know there were no Rule 35 2 reports.
I suppose it's where that threshold is, and whether we would do a part 1 because of deteriorating mental health, or whether because suicidal intention, I think these are my personal opinion is these rules have been put in place by people with no medical training, and if someone is suicidal, why is that not a 1? Why is that a 2? Because that's got to be to do with their
because
mental health.
The rule says so.
No, that's why I said in terms of that, my point was that those are rules not put in by anyone with clinical experience. It doesn't make sense to separate the two. You would agree, right? It's a mental health issue if you're suicidal.
Of course.
Absolutely. So,
in relation to self-harm, that in itself, even short of a suicide attempt or suicidal intentions, indicates a deterioration in someone's mental health, doesn't it? An act of self-harm.
An act of self-harm can indicate. I think it's difficult. I think it's really quite separate to conflate self-harm with suicidal intent, because they're quite different.
Yes, and I'm asking about self-harm, not suicide.
So just self-harm. Go on.
So an act of self-harm indicates that someone's mental health has deteriorated, doesn't it?
It means that I suppose deterioration being that they're suffering mentally from that. Yes.
Yes, and so that would indicate the need for a report under Rule 35(1), wouldn't it?
I think it's important to differentiate fluctuations in mental health, and so, for example, as a clinician, there are individuals that will self-harm. It's relatively common, unfortunately, in today's population, not just immigration, as a means of coping, as a coping strategy. So to conflate the two and say someone is, self-harming, they need a Rule 35, then how many Rule 35, I suppose implementably, how many Rule 35 ones would you have to do? Would you do one? Does the rules give any guidance as to how many Rule 35 ones you would expect to be doing? Is it at every point someone self-harms? That would be my...
Well, an act of self-harm may be an indication that a detainee's health was in fact being injuriously affected by detention, mightn't it?
It may be, absolutely.
And so consideration at that stage should be given to a Rule 35(1) report, shouldn't it?
And I think that's I think that's why we try to... I think it's difficult. We were always aware of people's mental and physical health, and we were always managing, not just about whether they should be detained, but managing their mental health.
So we know that in 2017 there were only 8 Rule 35(1) reports completed. There should have been significantly more than that, shouldn't there, given the number of ACDTs open?
It depends whether you feel that... It depends what you feel the role of the Rule 35 was. If the intention is to say, well, because we're considering detention, in the Rule 35s, it's about consideration of detention, rather than just... It's always in that context of detention within the immigration centre. Are they suitable for detention? And that's always going to be the case. The difficulty is it puts the clinician in a position where you say their mental health is deteriorating, they've self-harmed, are they now fit for detention? And if we were to write, actually they are suitable for detention at the moment, then the clinician is put in a very difficult position of identifying that they are not fit. And then if that is rejected, as an example, do you then resubmit one when they self-harm again, or actually when they get better, do you reject? Do you say actually?
If they're deteriorating, you
But
should be
it's
writing
that-
a Rule 35(1) report, shouldn't you?
No, so I think if someone is deteriorating, but it's that document is a static document. It's not. It's a weighty document that needs to be. That takes time to complete. I'm not saying we don't complete it. We have, rightly or wrongly, we have always tried to improve our therapeutic outcome. What we try not to do is conflate everything with detention and Home Office. We've communicated changes in mental health and appropriately to the Home Office.
So what is the explanation for there only being 8 Rule 35(1) reports in 2017?
Because I think the management of that patient, I would assume, because I haven't got all those documents, but actually those patients were able to be managed within that detention environment, and therefore it wasn't felt. And that was the threshold that was in the Rule 35 documents about can you manage these patients in. And if you're
So
saying...
you felt it was appropriate not to write Rule 35(1) reports where their health could be managed in detention?
I felt that that was certainly an aspect to it. And I think look, as a clinicians, we absolutely want to do the right things by our patients, and we want to be able to deliver better outcomes for them. And I think if you are able to, if we're at the coalface and you're able to deliver a much clearer methodology and system that works, that's what we're looking for. That's what we wanted. And we've always asked for that, hence why we've gone straight to the Home Office. But we've never received that.
Were you saying to the Home Office the Rule 35 system isn't working?
Yeah, absolutely. We're not to said it.
Who were you saying it to at the Home Office?
The names of the people.
If you can remember them, yes. Or their roles.
I could provide you with the email contacts of that. Absolutely.
That would be very helpful.
Because it's as clinicians we want to get on and look after our patients and
Yes.
and
If I can just pause you, because I've got a
Sure,
large
sure.
amount to get through.
No, go through. Apologies.
Did anyone at the Home Office ever raise with you that they weren't seeing Rule 35, very many
No.
Rule 35(1) reports and no Rule 35(2)
No, and they would have
reports?
been aware of it, right? Even at the teachings, that was they were fully aware of that. That was never raised. And they would have been aware of the number of ACDTs as well. So that information would have been
Yes.
in front of them.
Yes, thank you. Chair, I'm conscious of the time. I just have one last section on this topic, and then perhaps we can take a break.
Thank you, Ms Simcock. Thank you.
Just in relation to Rule 35(3 then, given we've dealt with the other two limbs of the rule, really these were the reports that you were completing where they related to someone who may be a victim of torture, is that right?
Yes.
And is that still the case?
Yes.
Perhaps we can just look at the template for the Rule 35(3 report. It's at HOM 002591 and it's at page 28. So this is the template that was in place at the time in 2017 because it's dated from 2016. You mentioned that it had changed previously. There was one form, and you would then select under which limb.
And you could do multiple.
And in relation to this is the Rule 35(3 report template, and as you said, the other two again had their own templates; they were separate. Did you understand, though, that you could write a Rule 35 report under more than one limb of the rule at the same time?
Yes.
In
But
relation,
we didn't.
you didn't do it.
Can
Why
I say
not?
why? Yeah.
Yes, why not?
Yeah. No, the reason is because all the Rule 35s would have gone to the same email address or the same person who responds to them.
Yes.
All the information would have been within this document. So anything that we were to put onto this document would have been what we would then be putting onto the Rule 35(1). So if we had concerns about deteriorating mental health, those would have been
on
in
the Rule
parts
35.3.
in section 6, it asks you specifically about that. So it didn't feel, given not just time constraints but duplication of information, it didn't seem relevant to cut and paste all the same information, put in another document which was going to the same person.
I see. If we look at page 31, please. We see there the assessment that you're required as a GP to carry out of the detained person. And in relation to this particular limb of the rule, in relation to someone having been a victim of torture, it wasn't simply about the physical findings and assessment, was it? It wasn't just about scarring. It also directed you to consider the person's mental health.
Yes.
You were also required, as you see from the third bullet point there, to consider and make an assessment of the impact of detention, the impact detention is having on the detainee and why, including the likely impact of ongoing detention. Is that right?
Yes.
So it was your duty as a GP in making this assessment to explore those aspects with the detained person in front of you, wasn't it?
Yes.
And that would include you positively exploring it, not just waiting for or allowing the detained person to volunteer information. You would ask
Correct.
questions.
Yes, we would.
And that would particularly be the case in relation to their mental state and their mental health. Is that right?
It would be, yes, we would explore.
And that's particularly important in relation to victims of torture because it's recognised that people who have experienced trauma may have difficulties in speaking about that trauma. Did you understand that at the time?
We would approach and we would be sympathetic and talk to patients and spend time with them.
Were you aware that PTSD as a condition was particularly prevalent among victims of torture?
I think PTSD, is well recognised.
And
amongst other mental health illnesses,
amongst
should be.
Yes, absolutely. And avoidance and withdrawal are known to be symptoms of PTSD, aren't they?
Yes, amongst other conditions.
Amongst other things. The form itself at section 5, and that's page 30, please, asks for your objective clinical observations and findings, doesn't it? Right, that please provide details of your objective clinical observations and findings, and then it says what that should include.
Yeah.
So again, it wasn't just what the person was telling you, you were required to make an objective assessment of them.
Yes.
We know that a large number of the Rule 35.3 reports completed during the relevant period, approximately 3/4, didn't consider the impact of detention upon the detainee. Why was that?
I don't know why that should be, but I suspect part of that is the very challenging dual role that the GP was put into as an advocate of the patient, but also responding to the Home Office. So if the GP was to say something, and this is a copy that goes not only to the Home Office, but goes straight to the patient as a straight off, to say, actually, this patient is currently managing well in detention, they are fit for detention, and we're meeting them, as in we are meeting their medical needs at the moment. If it was to be written in that, the patient would look at that document with suspicion that we were colluding with the Home Office, and I suspect, and that would break down a very difficult relationship as it is, because we're the frontline people almost representing the Home Office, although we don't regard ourselves in that, but that's how it would be construed.
I see.
And so I suspect it's not written down in some of those cases. I don't think that's necessarily the case now. I think that practice has changed.
Okay. Because you were aware that the Home Office is considering the impact of detention on detainees, and indeed the form directs you to give your assessment of it. That's right, isn't it?
That is correct.
And so if the impact of detention is not assessed or documented, the Home Office isn't able to consider that information in their detention decisions, are they?
So if you were not to write that statement, which is why that practice is changed for that reason, but it means that we are now again in a very difficult situation as clinicians from a very suspicious client base, if you will, patient base.
Yes. Were you aware at the time?
But also, and in addition to that, the Home Office, so separate to this, if there were, so it was incumbent and it was practice that the Home Office would have healthcare inquiries. They would stop the clock and they would mention and say to us, is this the individual fit for detention? So although it's not documented on that, there might be supplementary cases, and a lot of them, where they would ask the question. And the Home Office did ask questions, so it's not an odd practice. It's out of the blue. We would get, stop the clock, you've not mentioned this, can you please mention it? And we would.
Were you aware at the time in 2017 of the Home Office explicitly relying upon the absence of such assessments being documented as being an indication that detention was not having an impact and therefore justifying continued detention?
I was not aware of a practice that you're describing. That's not something that I would have been aware of.
Thank you. Time for a break. I suggest 10:02.
Thank you very much, Ms. Simcox.
Thank you.
Thank you, Dr. O'Reilly. See you in 15 minutes. Thank you. Thank you very much. Thank you, Ms. Simon.
Thank you. Doctor, I have just one last general question to ask you before moving on to some specific individuals with whom you were involved. You mentioned in your evidence before the break that under Rule 35, the requirement is for the medical practitioner, that's you, reporting to the manager on the case of any detained person and then under the different limbs. Who did you identify as the manager for that purpose?
I believe Sandra Cavill was the manager at the time, I believe.
I see, thank you.
I assume it means healthcare manager.
Was that your understanding in 2017?
I would believe so, yeah.
And is it still your understanding that the manager referred to within the rule is the healthcare manager?
It is.
Not the manager of the centre?
No.
I want to look, please, at the case of D1527. Could we have on screen, please, CJS 001002, please, at page 30? And yes, and if we could just go down, scroll down slightly to, yes, the entry on the 4th of April at 19:26 hours by staff nurse Lynn O'Doherty. This is his screening on admission to Brook House on his arrival. And we see there that he was quiet on admission and on an ACDT for suicide threats, 3 obs per hour, no current thoughts of self-harm or suicide, and an RMN mental health nurse referral was made, and he was given a slip to attend the MO. Is that medical officer appointment tomorrow?
I didn't write that, but I would assume that's what it meant, yes.
Yeah, so that they're referring to the Rule 34 appointment with the GP that's required to take place within 24 hours of arrival at the centre.
That's what I would take from that, yes.
Yeah. On the 5th of April, if we go over the page to page 31, he was seen by Dr. Chowdhury at 15:20. It's the entry just at the bottom of the page there. And it says history, patient mentions has been on antidepressants in the past, mentions has had mental health issues in the past. Looking at notes, was previously on, and that's a medication, issued the same and advised to see mental health team, not actively suicidal, review by RMN. We know that when D1527 arrived from where he'd been held before, he was on an ACCT, so that's the ACDT equivalent in a prison, is that right?
That's my understanding, yeah.
And that again would was marked in his records, and he was on a self-harm or a risk of suicide observations under that document. That would be your understanding of what an ACCT would do.
Yes.
No Rule 35 report was completed in relation to D1527 in these circumstances. Do you know why not? Would you have an explanation of why not?
Oh, that's really loud. Yes, yeah. I thought that she'd mentioned that he didn't have any suicidal intentions. Is that not correct? On the last slide, did you not say?
Currently, no
Yes.
suicidal intentions.
So if someone doesn't have any suicidal intentions, that wouldn't necessarily lead to a Rule 35? Is that not correct?
Should there have been consideration of a Rule 35(1) report, given his previous history of self-harm, his mental health issues, and the fact he was on antidepressant medication?
I don't think necessarily someone being on an antidepressant medication would mean that they are likely to be injuriously affected by detention.
But
Having come from a place of detention, it seems that he was at a previous prison, is that correct?
He was at a prison previously, yes.
And
but
it seems that he'd improved as well, because he was on 3 hourly obs, was it, from the last screen?
Yes.
So he had expressed suicidal intention. He no longer, so that would imply, only from the information here, and I don't know the patient, that he was improving.
But
Would
it's
it
a
not?
combination of factors, isn't it, that are required to be considered under Rule 35(1) in considering whether detention is likely to be injurious. And he had a history of self-harm and mental health issues and was currently on antidepressant medication. Wouldn't that at least prompt consideration of a Rule 35(1)
But
report?
it seems to be from the information. Again, I'm only commenting on the information that I can see in front of me. That his health has improved, so it's not likely to hit the threshold of likely. You'd have to. How would you evidence that it was likely to get worse if in fact it had improved?
He goes on to disclose a history of torture. It's noted, and who we have up on screen, please, CJS 001123 at page 3. So this is his Rule 35 report, and you've noted he has difficulty sleeping. He occasionally has memories of what has happened in the past, but his feeling relate to his experiences as well as the immigration case. He says there are two issues. He says he was seeing mental health team regularly before detainment and is currently on antidepressants. He says he tried to kill himself in Belmarsh prison, and he does not regret doing this. He has met with the mental health team at IRC and given a plan of how he plans to kill himself. He says he has negative thoughts every day and tried to end his life 3 days ago. He is now currently on an ACDT. And this is the assessment that you carried out on the 13th of April, following requests from his legal representatives. Do you remember this?
I don't recall the patient there, or the entry. Sorry.
This is a Rule 35(3) report. Should what's recorded here also have given rise to a suspicion that he had suicidal intentions?
Should it have speculated on whether he had suicidal intentions? Is that what you're saying?
Should what's written here give rise to a suspicion that he has suicidal intentions at this time?
Which is why I asked the question. So are you saying it should?
I'm asking you.
But I'm unsure of the question. That's why I'm clarifying.
Should what's written here have given rise to a suspicion that he had suicidal intentions, in your view?
You've just repeated the question, but rather what I'm looking to clarify is whether you're asking me whether I should have explored whether he had suicidal intentions or commented on that he historically had suicidal intentions. I'm confused with the question.
Do you think that what's written here indicates that he had suicidal intentions at this time?
Does this, so what I've written here, it doesn't imply that he does have suicidal intentions.
Did you explore whether he had suicidal intentions?
I can't remember the case. I would have thought that I had. And
He
given
says-
that he was actively on an Acdt, that would have been an area that would have been explored during his Acdt reviews.
He'd said he'd tried to kill himself before.
And it says he has negative thoughts every day and tried to end his life 3 days ago. So the implication would be that might be a consideration, yes.
No Rule 35(2) report was completed on this occasion.
And I think this probably highlights what I mentioned to you earlier, that if all the information is in a document that is going to the same person, simply to duplicate that, I'm not sure how productive that would be. Because it wouldn't change. If I cut and pasted this as an example to another document, would that reinforce it? I'm not sure.
Just because there's a Rule 35 report under one limb doesn't preclude a Rule 35 report under another limb, does it?
Well, it depends whether you view the document as a document to be completed like a tick box, or whether you understand the essence of the Rule 35, which is a communication of vulnerability, which you mentioned, to the people. And if the information is being passed to the people that need to know it, I'm not sure how opening a second Rule 35 would have benefited or changed an outcome, because you're already making the point and having the information there. I mean, unless I'm missing something.
In section 6, which is the next page, please, you say he appears credible. He may be a victim of torture and his scars are consistent with the account. He clearly has mental health issues, but I am unsure whether detainment has a negative impact on this, as he has tried to harm himself in the community. What did you mean when you said I am unsure whether detainment has a negative impact on this, as he has tried to harm himself in the community.
So we're there to comment on the impact of detention, and I'm unsure of whether detention itself is leading to his situation, or whether there are issues other than that, either coping strategies or arguably whether the immigration case alone. So actually, how much of a factor is detention in the way that he's presenting?
But isn't it obvious from what you've written in this document that it already was having a negative impact on him, wasn't it? He had negative thoughts every day, plans to kill himself, and he'd attempted suicide 3 days previously.
But that's to assume that detention alone is the only reason he is doing that, rather than if he was outside in the community and he had a Home Office case of impending deportation, would that have had the same impact? That's the bit that is not certain. So I think to conflate the two and say, is detention suitable? Are we able to manage him or give him or treat him his condition? Is detention, if you remove that person from detention, would they suddenly get better? And I think the vulnerability aspect that is continuously being considered only simply almost implies that detention alone is the cause. You remove detention, they get better. And I think that's the danger with all of this.
But,
that's the broader point. I appreciate that's not what you're making.
Weren't you aware, though, that where people were victims of torture and had experienced, therefore, trauma in their past, that they were particularly vulnerable to a risk of harm in detention? And that's why the Home Office policy was only to detain them in extenuating, exceptional circumstances, as the slideshow showed earlier.
So I've said I'm unsure of detention, because I think it's unfair on clinicians to be put in a position where you're asking for a refutable point to say, he's not fit for detention. And I don't think anyone in this room would be upset with me if I wrote that. But could I write down the evidence that says this individual? So on individual cases, there is...
But he had attempted suicide 3 days previously in detention. He was saying he had negative thoughts every day and plans to kill himself.
Yeah, so his mental health is being managed. What I'm saying is detention alone, is that causing it? Is it purely relation to detention, or are there other factors?
Well, he was a victim of torture.
So that just means that he is vulnerable to other mental health issues. That just means that PTSD, anxiety, depression, all of those things are within that differential. But what I'm saying, and I've said he's credible, I've said he's a victim of torture, I've already said he has mental health issues. That information has been passed to the Home Office through this document, and I guess what I feel is being pushed is, why have I not just said almost like I can't comment on... I'm writing this information to a non-medic. I can't explore, have a medical conversation with that person. I'm just saying, here are the facts. I'm unsure of that. I'm not saying it is or it isn't. I'm just highlighting the difficulty in that decision. I don't think that's unreasonable if you're not sure of that you should be allowed to say, I'm unsure of.
In relation to D1527, we know that just after midnight on the 24th of April, he was transferred to E-Wing because his cellmate had alerted detention officers to the fact that he was self-harming, and he was found with a ligature. Later that day, at around 3:30, in the afternoon, he was again found with a ligature around his neck in bed, requiring officers to intervene by force. He was placed on constant supervision as a result, and we've heard evidence that DCO Calvin Sanders was responsible for his observations. You visited him during this period, and it's an entry at 13:40 on the 24th of April at CJS 001002 at page 37.
It's not up there.
Sorry, 001002. go, at page 37. And it's the entry on the 24th of April at 13:40 hours. So there we see that your name, history, C in E-Wing. And if we go to the next page, please. When I entered the room, he was asked if any medical issues. He has said there are none. This was at a time when there had been a ligature found. His cellmate was concerned about his self-harm. He'd superficially cut his wrist. And then he had ligatured a second time. Were you aware of those things when you saw him and made this entry?
I can't speak for the exact date. I would have assumed that, having seen him and known that the individual was an ACDT, that I would have been aware of that history, but I can't for certain remember the exact, what I recall at that time.
Do you think you would have been aware of the reason he'd moved to E-Wing?
I usually ask, so I would have thought...
Ask who?
It would be the officers and the nurse that I would be going down with.
I see. What was the reason you were seeing him?
I imagine, because he was on E-Wing, right?
Yes.
That's what you're saying. So we would go down to E-Wing and do the rounds and see those patients that were on ACDTs and on our way to CSU, because at that point they weren't able to access healthcare. So that would be a means of identifying healthcare needs.
You don't appear to have given any consideration as to whether he should be being managed on E-Wing. Do you think you did consider that at the time?
Generally, the location of a patient was not something that I would be involved in deciding. The appropriateness of the location, that's what you're saying, right, E-Wing?
Yes.
Yeah, so it wouldn't be a decision that I would have had control over.
Would you have had any concerns about him being managed on E-Wing?
Individuals who on ACDTs would often be managed in E-Wing, often. I know that people on ACDTs were managed on E-Wing.
Yes.
Because they were, I think they had a see-through door, and so that the officer could therefore monitor them, and there's not so much flow of patients and detainees around. So I assume that's often why they chose that location.
You didn't complete a Rule 35(1) report on this occasion. Why not, given what we know had happened immediately prior to this?
So you're talking about sort of acutely writing a Rule 35(1) for deteriorating mental, or a Rule 35(2). I think for the reasons that we've discussed prior, it was not the common practice, and remains not the common practice, to complete the Rule 30 purely. The
threshold for Rule 35(2) had been met, though, hadn't it? He'd attempted suicide with a ligature twice, and the threshold for a Rule 35(2) report is a suspicion of suicidal intentions.
So this is the individual is that the same guy who just had a Rule 35?
He had a Rule 35(3).
Yes.
I'm asking you about Rules 35(1)
No, I appreciate
and
that.
2.
So it is the same individual that we're talking about.
Yes.
So that, I suppose this highlights the flaw in the Rule 35 process, is that whilst you say the rules say we should be doing that, it doesn't indicate how often and how many times, and it doesn't really take into account a lot of those details.
But shouldn't the rule apply whenever the threshold in the rule is met?
So by the book, absolutely, I don't dispute, according to exactly that rule, that individual should have one, but that was not the practice at the time, continues not to be the practice.
And that was even though he was on constant observations, indicating a high risk of suicide.
Yeah, because it would be, again, it was a means of communicating vulnerability, and that that would have been through a Part C to the relevant authorities, the Home Office. It would have been, that's the way that was communicated, and it would have been discussed in an ACD to discuss how his mental health and his physical well-being were being looked after. So yeah. So that's the reason it wouldn't have been done, because it's not the practice across any of the IRCs to do it in that way.
On the 25th of April at around 5:10, he was placed on a Rule 40 removal from association in his E-wing cell. And at around 7 p.m, he was found by DCM Steve Lawton around the toilet of his cell with a ligature around his neck. Force was used to cut off the ligature, and in the aftermath, he continued to be distressed, and he was mocked by officers, and that was one of the incidents that was shown on the Panorama programme. He then attempted to self-strangulate, and officers entered his cell, and he was restrained by, amongst others, DCO Pashali, by using his hands around D1527's neck in what's been referred to as a chokehold, in front of 3 other officers and a nurse. You saw him the next morning on the 26th of April at 10:36, and it's CJS 001002 at page 39. So it's the 26th of April at 10:36 at the entry at the top of the page, and it says history seen in E-wing. He says he feels well today. Sorry, you scrolled, it's now at the middle of the page. He says he feels well today and no medical problems. I believe he presented with challenging behaviour overnight, but settled and later became cooperative. How would you have found out that he had presented with challenging behaviour overnight?
I would have spoken to, it might have been the nursing team, maybe through a handover. I'm speculating because obviously the time, and I don't know the patient. And it could have been through speaking to the officers. Maybe if he was still on an ACDT, which I assume he probably was at that point, I would have asked the officer who was looking after him.
Would you accept that challenging behaviour doesn't really accurately reflect the serious attempt at self-harm and suicide that I've just described had happened the previous night?
I don't think it's a detailed... I wouldn't have known anything other than what I was told then. So what you've described, if you're saying, that's a serious sequence of events, and absolutely challenging behaviour doesn't really give it justice.
Yes. Do you think, given this description, that you weren't aware of that previous history?
It's possible. I don't want to say. I don't know is the truth.
On the 4th of May... 2017, D1527 jumped on the suicide netting, and that again is an incident that was seen on the Panorama programme. Do you remember that? So did you watch the Panorama programme?
When it came out, I haven't watched it since.
There wasn't any Rule 35-2 report completed then, despite him threatening to kill himself using a broken plate and jumping on the suicide netting. Is that again for the reasons you've already given in relation to Rule 35-2? But shouldn't one have been done then?
I think for the reasons I've given you, I think that's probably a bit of a rhetorical question. I don't think it is the practice that everyone who...
But shouldn't it be?
But I said, from what you've said, and the Rule 35 by the letter of the law, then it makes sense that it would be. But again, I'll emphasise that is not the practice and hasn't been in the last 7 or 8 years, not just by myself, by anyone in the immigration sector, and it's never been raised or corrected, or there's never been mention of it.
On the 22nd of May 2017, the IMB reviewed his records and considered asking him to sign a life directive because they feared that he might die from food and fluid refusal. Were you aware of that?
Do you mean an advance directive?
An advance directive, yeah. Yes.
Yeah. I don't recall the case in that, but if I can't say I knew or didn't know about it.
Again, food and fluid refusal resulting in a concern that someone might actually die would raise a concern about a suspicion of suicidal intentions, wouldn't it?
Yeah, so food and fluid refusal doesn't necessarily imply that there is suicidal intent, and I think that depends on the individual. I can't speak for this individual, but there are a broad number of reasons why people choose not to eat, or to starve themselves, or to take fluid, and we would approach that on a case-by-case basis and discuss that. I'd be involved in talking to them where they were happy to talk to. I think a broad brush approach to food and fluid is probably not helpful.
Dr. Thomas visited D1527 on the 20th of May and prepared a report on the 31st of May, and she reported that he was making nearly daily suicide attempts. Were you ever aware of her report?
Sorry, Dr. Thomas, from what organisation is it? Is it an organisation, or is it one of our GPs, or?
No, it was, I believe, yes, it's an independent doctor.
From what? They wouldn't be allowed on. They must be part of an organisation.
Yes.
Yeah. So unless they were to pass me that information, contact me, speak to me, I wouldn't be aware of an independent report unless it was passed on to me.
In her report, she queries why D1527 wasn't in hospital, why he was not referred for psychological treatment, and she noted that he was considered to be at high risk of suicide. Did you ever consider transferring D1527 to hospital under Section 48 of the Mental Health Act?
So I take it that individual would have been under the mental health team? Are they?
Well, I'm asking whether
I'm asking were they, because that affects the answer to the next part of the question. So if they're under the mental health team, they would be reviewing, and there'd be an issue of whether someone would be appropriate to be sectioned under the Mental Health Act and then receive treatment. And then, again, I'm speculating because I don't have all the information, that capacity decisions would be important, whether the receiving hospital would have to decide whether they were happy to engage. There's a process to it. I think the idea that referring someone to psychological treatment is a little bit simplified. So I don't know the report. It is me talking completely in the hypothetical because I don't know that case. I haven't seen the report.
In terms of the treatment he was receiving in detention, he hadn't seen a psychiatrist. He was being managed by nurses. He was being managed on an ACDT to manage his risk
Can I
of
ask, you
suicide.
say he hasn't been seen by a psychiatrist. Had he refused to see a psychiatrist? I don't know.
No.
He hadn't refused.
No,
Okay.
He hadn't been referred to a psychiatrist.
Okay.
He wasn't seeing he was being managed by nurses, and he was making several attempts to commit suicide. He had no psychological counselling or therapy, and the treatment given to him was antidepressant medication. Do you consider that to be adequate treatment?
Do I think that individual probably needed more? Yes. Do I know the full context to that, as in the facts you outline? If he was engaging with and was happy to see and engage and talk to people, patients who don't engage, it's going to be hard for more intensive therapies, unless there might be reasons as to why he doesn't want to engage. I don't know. There's a lot of uncertainties before you can really.
Were you aware of, at the time, of the NICE guidance on the longer term management of self-harm?
I can't say what I knew at the time.
Are you aware of them now?
Of self-harm.
The NICE guidance on the longer term management of self-harm.
I can't recall the exact, but I would be aware that they are there. I wouldn't be able to recall them verbatim.
You don't recall the content?
No, not off the top of my head, no. But we can refer to them as clinicians. That there's access to.
We've talked about how the practice of how when a Rule 35(3) report was done, there wasn't then consideration of the other two limbs of the rule and doing separate reports under those limbs if they applied. Were you aware of a practice of refusing to do successive reports or repeat reports, even if asked by detainees to do so?
Pardon me. I think if we were asked to do so, the danger was how do I phrase? So the Rule 35s. If a patient were to ask me about, can I have another Rule 35 35(3), if that were to be that question, and I would ask the patient in this hypothetical context, did you have a previous Rule 35(3)? Was the information in that correct? And are the Home Office aware of that? You know, so I would approach it. If they said to me, all the information has already been done, but I'm upset, I wasn't over-released, and there was no additional information, I might write, and I can't speak for that time, and this is hypothetical, but what I would do, if someone had a Rule 35 even a week ago, or even a month ago, or prior to being in the hour, I would write to Home Office saying this patient has had a Rule 35. The content remains the same, just to let you know, to highlight. Because I don't know how their filing system works.
What about
if that's what you mean about the Rule 35(3)?
What about if they had a Rule 35(3), but then their health was deteriorating in detention? Shouldn't there then be consideration of Rule 35(1)?
No, that would be reasonable. Yes, absolutely.
Were you aware of a practice, or was it your practice, to nevertheless refuse to do those reports?
No, that's
Well,
not
we
true.
know that you didn't do Rule 35(2) reports in those circumstances.
Not in those circumstances. I said that the Rule 35(2) was almost considered slightly differently, where we would be updating. The Rule 35(1), however, is if we felt someone's health deteriorated, irrespective of a previous Rule 35(3) or even a 1, if we felt that it was getting worse, we would be communicating that to the Home Office. There's no shadow of a doubt.
It doesn't appear that you did so in the case of D1225, though. If we could have on screen BHM 4031 at page 21. Sorry, I think I'm in the wrong page. Just 4031, page 21. I should have had 57A. Yeah, there we go. Thank you. This is the case of D1225. It describes that he's an Afghan national who was already in receipt of a Rule 35(3) report completed when he was at Heathrow IRC before he transferred back to Brook House. He expressly requested that a further report be prepared on the basis of an error in the previous report. He also disclosed a new allegation of rape, which he had not previously disclosed and therefore was not captured in the previous report. And if you go over the page to page 22, please. Notwithstanding this, you, the GP who saw him, refused to carry out a further Rule 35 assessment on the basis that one had already been done on the same events. Instead, the doctor used the IS91RA Part C form to inform the Home Office of the additional disclosure. And this witness comments that you failed to investigate whether he was suffering from any psychological symptoms or mental health concerns arising from this specific trauma, and the extent to which the current detention was impacting upon him. Do you remember this case?
I do not.
Is that something that you consider you would have done?
No. Well, no. I think that there are aspects to which is what I just said. If someone was asking for a Rule 35 to declare the torture they'd experienced, if that was the case and it had just been done, or it'd been done but the details were there, I would inform the Home Office rather than duplicate what had already been done if the facts were correct.
So this is part of your practice again of using Part C instead of Rule 35(1.
Which was the means of communicating. I think the idea that I had failed to investigate implies that a Rule 35 is the only platform in which we would investigate psychological trauma and mental health, and also that it is only the GP who investigates mental health issues within that centre.
But it's only the GP who can write a Rule 35(1) report, isn't it? And that's what he was asking for, a Rule 35 report.
I mean, this is third-hand information because I don't know any of this. So I'm only going on what you've had there, and you're asking me to comment on something I have very little information apart from someone who's insinuated that we're not dealing with the mental health issues,
But
and I don't know who that is.
again, the Rule 35 process is designed to trigger automatically a review by the Home Office of detention, which Part C doesn't do, does it?
No, and I would disagree. Our experience over many years working practically on site and dealings with the Home Office is the Part C was frequently used and did trigger the release of patients. So it's not my experience. What you're describing is not the experience of people working in that environment.
You could take that down, thank you. If we look then at the case of D643, on the 26th of April 2017, D643 was referred to you for a Rule 35 assessment, and we have his medical records at DL 40217. If we I'm looking for, so in his medical records on the 3rd of April, it was stated that he was feeling distressed and suicidal, and your note on the 26th of April, 26th of April, is at the bottom at 15:22. History says he feels that his mental health is deteriorating. He mentions that there are a few occasions where he feels his PTSD has returned and there has been a wave of anxiety. He feels in the last 2 weeks there has been a change in his behaviour. There's an examination noted. He presents composed and alert with no hypervigilance but appears in low mood. He maintained good eye contact. And it says, plan, I have advised that in this instance I feel it more appropriate that he contacts the mental health team and they can consider referral to psychiatrist if appropriate and monitor his progress. I do not feel a Rule 35 is appropriate at this time, as I have not observed a deterioration and he does not appear acutely unwell. I have spoken to the mental health team and they have informed me that with regards to treatment there are options for him. I also acknowledge that he feels this environment has more triggers for his PTSD that he cannot avoid. He politely excuses himself from the room, disappointment with my suggestion, which I had to repeat a number of times. So he was reporting that there'd been a change, and the records indicated that he was feeling suicidal. He was suffering from PTSD and was reporting to you that detention was triggering his PTSD. That's what this note indicates, isn't it?
He subjectively said that, according to the records.
And you were concerned enough about his mental health to suggest that he saw the mental health team to consider referral to a psychiatrist. Is that right?
Because he was saying that his PTSD, so I thought it appropriate to explore therapeutic outcomes.
But you didn't complete a Rule 35-1 report or a 35-2 report, and you said that you didn't feel that a Rule 35 report was appropriate. Why wasn't it appropriate?
It's whether, so it's subjective and objective clinical observations. Now, whether you choose to agree with that clinical observation or with the patient in front of you, as I would have done, that's the point where you...
Didn't you believe him?
When you assess mental health, it's not a case of patient walks in. Sorry, I don't mean to say that. It sounded confrontational.
Could you just answer the question? Did you believe him, do you think, from
It's not about believing.
But
There's
then
subjective and objective measures when you do a clinical assessment. That's what I'm saying.
He is reporting a change and that his PTSD is being triggered by detention. Isn't that exactly the scenario that Rule 35-1 deals with?
No, I don't think it does.
His health was being injuriously affected by detention, wasn't it? Actually affected, not likely to be affected, but actually affected.
I considered, so the criticism is that I have not done a Rule 35, and I've explained within those entry that I have considered it. So it's the consideration of a Rule 35. You're suggesting that I should have done a Rule 35.
Do you think you should have done a Rule 35-1 report, given he was... Listen to the question. Do you think you should have done a Rule 35-1 report, given that you've recorded that he has told you his PTSD is being triggered by detention?
I've documented that I made a clinical assessment and I didn't feel it was appropriate. I can only speak from the records that are there.
On the 15th of January 2018, you completed a Part C form, and that's at DL 40235. It's a little difficult to read. In Part C, you said that you feels his mental health is deteriorating due to his prolonged detention and the multiple triggers for his PTSD within the centre. He is disengaged from the mental health team as he feels they do not help him. He has a report from a psychiatrist, independent, verifying his mental health, June 2017. So he was deteriorating, wasn't he? According to this note.
I think it says he feels his mental health is deteriorating. So subjectively, he felt that.
And he disengaged from the mental health team, and he had a psychiatric report verifying his mental health.
That's what it says, yeah.
Why did you not complete a Rule 35.1 report at this stage?
I think the very fact that I put so much information into that Part C implies that that was the means of communication to the Home Office about an ongoing mental health issue.
So it's again an example of the practice of using Part C instead of Rule 35.1.
That's what, to me, when I see that. It shows that there's an acknowledgement and there's an ongoing care and consideration, but it was...
On the 12th of March 2018, you sent a letter to the Home Office stating, in response to the Home Office inquiry, the detainee is fit for detention. We believe he is getting adequate care. He is not on any medication. He remains fit to fly. I'm going to come to the practice about certifying fit for detention and fit to fly in some detail in a moment. But why did you consider it was part of your role to provide a positive approval for detention and for flight?
I imagine the question was asked.
By the Home Office?
Oh, I would assume, from what you're describing. I haven't seen
there's no record in this letter of an assessment being done for the purpose of writing this letter. Would you carry out an assessment of the patient at the time of certifying fit for detention and fit to fly?
So we would use, it wouldn't be documented. So the question would be very clear, and we are answering the question to someone who's not medically trained. So we wouldn't just put the justification in a letter. We would be reviewing the notes and then writing, for example, if they were fit or not fit, if that was the nature of the question.
My question was about assessment of him.
So assessment would involve, it might be a face-to-face, I don't know, I can't speak for that particular case. It might go on previous consultations, it might go on collateral history.
If you weren't assessing him for the purposes of this particular time, the last assessment that's recorded is the one that we just looked at in Part C, where he was reporting detention was affecting him and he was deteriorating.
So if you're saying if I'm not assessing him, are you saying that he wasn't seen by anyone before at all?
Well, I'm
Is it just,
asking
are you referring
you
to my assessment?
your assessment.
Okay.
So if you didn't assess him at this time in March for the purpose of writing this letter, the last assessment by you that's recorded is in relation to the 15th of January, the Part C we just looked at. And that assessment recorded that he was reporting his PTSD was being triggered in detention. Why, given that fact, were you certifying him positively as fit for detention?
Okay, so we work as a healthcare team, so there would have been multiple factors. It might be mental health, might be that level of communication. Can't speak because I've got you know, I haven't got any information in front of me to go through the records. But as a healthcare team, I would rely on my mental health team and the people around me that I work to provide that information. So I wouldn't necessarily be my judgments aren't exclusively related to myself and my assessments. It's part of a team, and you've got to trust the people within your team.
But where the detained person himself was reporting that he was deteriorating in detention because his PTSD was being triggered, why did you feel able to certify him as fit for detention?
So I would have had collateral information with me, and subjective. Every assessment is subjective, as well as objective. And I think just to purely go on a patient communicates their symptoms to you and you are verbatim, and that is there's no need for a mental health assessment if you can just ask the patient everything and they tell you what's wrong with them. That's the whole point of being clinical, is you can think objectively as well.
On the 22nd of March 2018, D643 wrote a letter of complaint about your refusal in February to complete a Rule 35 because he had two previous Rule 35 assessments, both of which concluded he was unsuitable for detention. They had been over a year old, though. And his letter of complaint records, when I arrived in Dr. Ali, he got your name wrong, but it's clear it's you. When I arrived in Dr. Ali's office, he asked me if I have been tortured, because that is the reason people usually do Rule 35. I tried to explain that I am an adult at risk and my circumstances has changed from the last time I had my 2 Rule 35 done. I also had these independent evidence with me. But Dr. Ali refused to listen to what I have to say and started to be very aggressive with me. By then I was very upset, stressed out and emotional, and Dr. Ali refuses to take my evidence. Again, he concentrates on my immigration case instead of what I was saying to him. He refused to give me the assessment and asked me to leave his office because he did not have time to waste on me. He said is not getting anywhere with me, and it was if I was in a difficult negotiation and the other party was making it extremely difficult for me. It made me come to a conclusion never to go back to the medical centre again, as it is making me feel more worse coming out than going in. He was again reporting a change to you and saying that he had independent medical evidence to support it. Shouldn't that have prompted a Rule 35-1 report to be completed?
I don't know what the medical records... was that consultation the same as the from the other consultation that you mentioned? Because that's a letter from him, isn't it?
Yeah.
So I don't know what the clinical records... You're giving me what the patient
Well,
claims
you had certified him in the letter to the Home Office on the 12th of March as being fit for detention
But the encounter,
and getting adequate care.
The encounter that he's referring to, is that the encounter that I've seen him on the document that you showed me?
He's talking about when he saw you in February 2018,
Okay.
and you refused to complete a Rule 35 report.
So I don't recall the incident. I certainly don't behave aggressively towards patients, and I don't think that accurately represents any consultation that I've ever conducted.
Would you routinely ask detainees about their immigration case?
I wouldn't I think the immigration case plays a huge part, and their experiences in how they approach it and how they feel. So to not understand the triggers would be that's not appropriate. I wouldn't ask details. I wouldn't have an opinion on whether they should or they shouldn't. But it's not uncommon for patients to say, "Well, I got refused my asylum claim. I'm feeling really low." So obviously that is in relation to their immigration. So it would not be unreasonable to explore that.
Sure. Would you ask a detainee if they had a plane ticket, in other words, a flight booked for their removal?
So that's another trigger for people's low mood. If I've just been given a ticket by the Home Office, logically that's going to affect how I feel.
Do you think you asked D643?
I have no idea. I can't comment on that without.
Did you generally think if detainees were reporting mental ill health to you, or deterioration or self-harm attempts, for example, that they were using that to further their immigration case?
I think the whole process highlights why the Rule 35 is so messy, because you yourself have alluded to the fact that a solicitor requested a Rule 35 for their client previously. So the Rule 35, although you're in reference talking about sort of clinical outcome, I think that's what that you're referencing. Actually, it's different things to different people. So we would explore that Rule 35 with clients, with patients, and they would say, this helps they think it's an asylum claim. They have to go through this. They've been told by their solicitor, this is what, and the majority of Rule 35s that we would undertake would be at the behest of their solicitor. And
Did
the
you
patient
think-
would expect that was going to happen, and they would associate. They have to do it to get their asylum.
Did you think that detainees were manipulating the system?
I can't say who was manipulating or not manipulating. I think that the understanding, whether whoever's directing that it was critical to their asylum claim.
At paragraph 78 and 79 of your first witness statement, you say, the greatest challenge in carrying out Rule 35 assessments is that there has been a constantly changing landscape of the definition of torture and an increasingly broad definition of vulnerability. The effect of this, while outwardly suiting the purpose of advocacy groups, has meant an inevitable misuse of the Rule 35 and adults at risk policy and delays in the process. And you talk about some discussions with the Home Office you had about that. You then say the process of the Rule 35 has become diluted, and rather than exclusively identifying those at risk in detention and effecting change, has been a tool used by advocacy groups who threaten legal action at times in the asylum claims. Was it your view that Rule 35 was being misused?
I definitely feel that by the very fact that 95, I think that's the percentage of Rule 35s are victims of torture, so that it's been directed for a significant period of time where it was about that issue, that it was a means. And in fact, when we went to the Home Office to discuss it, we were identifying that actually it was the mental health and physical health assessments that were much more useful, rather than spending a lot of the time almost trying to document the actual means of torture, which ultimately it was not for us to decide if someone had been tortured or not. And our focus as clinicians is not about the torture. That's just, if someone claims they've been tortured from our point of view, that's enough.
You say that it led to delays in the process. How did it lead to delays?
Well, you had, I think I mentioned before, about the 3 or 4 week wait sometimes, because ultimately we are clinicians delivering healthcare, and if you have a 5 hours, 1 hour Rule 35s, 3 hours are clinics and Rule 34s, then if you are completing Rule 35s 1, 3 and 2 in different bits throughout the day in a population of what would have been about 600 patients, I think, in 2017, it would not be possible to actually run any kind of clinic, even if you wanted to, if you were doing the amount that it was expected. So it wasn't an effective safeguarding measure. The net was so broad for everything according to the rule that it wasn't practical, which is why clinicians across country chose it.
Doing them.
We're doing them in the way that we were. We were consistent with our peers. And Dr. Hard and Dr. Hard in his report acknowledges that.
Are you saying that detainees were requesting Rule 35 reports when in fact they didn't need one, it wasn't appropriate?
No, what I'm saying is that they were requesting the Rule 35s because that's what the definition, because that's what the Rule 35 rule was not precise enough to identify those who were truly vulnerable. And by that I mean picking up the cases that it seems that you have mentioned, where if there were no pre-booked Rule 35, I mean the idea that a Rule 35 is pre-booked actually in itself doesn't make any sense. It should be, I identify the need of a patient who's acutely suicidal and I do a Rule 35. But if you cannot physically do a Rule 35 and knowing that you're going to balance other people's health needs, I'm going to cancel my clinic, I'm going to do this Rule 35, that in itself is a problem.
The Shaw Review in 2016 talked about a culture of disbelief in healthcare. Is that something you recognised in 2017?
No, I don't think so.
Isn't what you say here in your statement indicative of a culture of disbelief?
In which part of the statement is
the one
disbelief?
I've just read to you, that there was an inevitable misuse of the Rule 35 and adults at risk policy.
That's not a
tool
disbelief.
for advocacy groups.
So there's a disbelief would imply that I don't believe the patient telling me in front of me. What I'm saying is that, and it's clear that the identification of the focus of therapy or treatment of our patient was purely on the basis that they need to be removed from detention, rather than the fact that sometimes it was the uncertainty of detention rather than detention itself. if a patient knew they were only going to be there a week, then that would be better. If the patient knew that they weren't going to, there'd be no notice removals, which I think have changed now, that would be better. That they could prepare themselves. It was the immigration. My experience is that it's the immigration uncertainty rather than detention itself, and the fact that, like I said, the victim of torture. The essence of someone declaring that they are a victim of torture would have been enough as a tick box. Do they declare they're a victim of torture? Tick. And then focus on the other aspects of their health would have been much more useful than what we would do is get an interpreter, work our way through the details. Does this scar match this? And it clearly says it's a role for GPs from the community to work with no special training required to work with this environment. And it says that. And so we're there defining whether someone's an actual torture victim. I think that in itself, the emphasis there is wrong. I don't think it's disbelief at all.
You mentioned in those paragraphs I've just read to you that you had discussions with the Home Office about this. And it
wasn't easy to get, it wasn't easy to get those discussions. That took about 6 months to a year to even facilitate a discussion.
And you mentioned two people in particular, Ian Cheeseman and Terry Gibbs. What was the response to you raising these concerns?
Everyone, we did a slideshow and we went through all the recommendations of the Shaw report off our own back. So this was a meeting that we'd organised. And everyone in the room was receptive to the fact that there were challenges with the Rule 35. This came along the same time that the adults at risk policy was being developed, and that was and this is a legal discussion between them, what counts as a vulnerable, and they all agreed. And one of the key points was we said, do you know what we don't is that we felt that the breadth. Well, we felt they ought to have a medical person within the Home Office who could to deal with that, and we felt also that they could be someone else. They can write their own torture claim in many ways because that's what they would be doing in their asylum. And we said the Rule 35 itself needs to change. And we gave an example of how it could. I think there was a template we did at the time. But their feeling was that it was, and they agreed that sometimes torture claims come through the Rule 35 process. So it was used in that. So even the Home Office were confused as it might be an avenue that an asylum claim might come through. But we were saying that's not the platform for that. That's not what we're there for. And that's not a good way to identify those that truly need input, and detention is really a problem for these guys.
I'd like to look at the case of D687, please. Can we bring up CJS 001139 at page 7, please? So on the 17th of February, he's reported by a nurse as detainee shouting and abusive in the clinic and very stressed. Clinical lead has suggested that he is reviewed by an RMN, and he is referred. He didn't attend on the 25th of February or the 1st of March, and there's no follow-up of recorded in relation to the reasons for his non-attendance. Routinely, a non-attendance at appointments wasn't followed up in terms of finding out why they hadn't attended at the time. Is that right?
I can't comment on that. You probably know more. I don't know who it was. It was not a GP appointment. It was a mental health appointment. They generally, I would have thought, and my experience of working with those individuals is they would have booked another appointment. And it does say, doesn't it? New appointment has been arranged.
He did attend on the 7th of March, and he gave a long disclosure about past abuse. He was recorded as being very tearful. He denied suicidality, but there was clearly here a presentation that suggested a mental health issue. Would you agree?
I haven't seen it. So what?
Very tearful and anxious as he ventilates his feelings, troubles and concerns. Reports that he came to the UK at the age of 8 years after his family and him flee from Somalia. Somaliland because of war, said both of him and his family was granted asylum and were given an indefinite leave to remain, disclosed that he was assaulted, but now with a vast amount of support and encouragement, as he was reluctant to do, very hesitant to disclose, said he did not say anything about anyone about it until the other day. He made it known to his mother but did not go in depth because his mother and sister was crying after he had disclosed it to them. Said he has been a troubled child since his ordeal and did not find courage to say it to anyone because of being ashamed and afraid. This is clearly someone who's presenting as vulnerable, isn't it, from this note?
Oh, I would agree with that.
He then missed several more appointments on the 14th of March, 20th of March and 22nd of March before self-referring back on the 23rd of March, and that's at page 8. We see there that he's made contact on the 23rd of March, but it doesn't seem as though he was seen then. Does that look right from this record?
On the 23rd of March, did you say?
Yeah, in the middle of the page.
Mental health referral form.
General letter to unknown, mental health referral form. It doesn't seem that there was a consultation at that time.
No, it doesn't appear the consultation. I suspect mental health referral means that maybe he was referred again. It's difficult to know from that.
Would you have expected him to have been seen on that date if he'd referred himself back?
If he referred himself back on the day, would he be seen on the day? I wouldn't have thought, unless there was an acute need that someone needs to be seen on the day. But it's not my call. This is not, the mental health team works separate from the GPs in that respect.
There are further concerns raised on the 11th of April. Received referral from security that he was using Spice. He stated that it was only once due to stress. Referral's been made to the Gatwick Detainees Welfare Group. One-to-one session on harm minimisation completed. Lower tolerance and overdose risk advice given to him. Spice use care plan created. He's now been recorded as using Spice, which was something of a problem in 2017 in the centre. Would you have expected more action to be taken on that occasion?
Not from that particular entry, because he's been seen and they've organised a plan is in place.
He's recorded on the 13th as angry and upset, given time to vent his feelings before returning to association. And he sees you on the 15th, which is over the page at page 9. When you see a patient, would you refer to the records immediately above? Would you review the medical
I would like
entries?
to think that I did. I would like to think that, sure.
Because it's important to know what his immediately past history was.
Yes.
Do you also ask him about what's been happening in the days and weeks immediately prior?
It is my practice to ask the patient, especially within the context of a Rule 35, about how things have been and yeah.
So your note records 3 lines down. He claims to have never disclosed this. That was referring to his previous disclosures about abuse in Somalia. He was not previously known to mental health services. He later discloses that he almost jumped from a bridge, but some friends passing by discouraged him. He mentions that in the last 3 months he has started hearing voices and gets very stressed and emotional. He also he had difficulty sleeping and is very concerned about being deported. He appears tearful on presentation. He is not on antidepressants but remains under the care of the mental health team. He will attend at 13:30 to sign consent. So he's reported a past suicide attempt to you there. Do you agree? Almost jumped from a bridge, but some friends passing by discouraged him. Also that he's hearing voices, he's stressed, emotional, and he was tearful in the consultation. He wasn't on antidepressants, but you note he was under the care of the mental health team. In fact, they had previously discharged him, and he had referred himself back. Did you consider prescribing antidepressants as a result of this consultation?
The role of it doesn't look like it does not say that I didn't consider it. It doesn't look like I decided at that point it was required, and antidepressants don't necessarily define someone's depression.
If you had considered prescribing him antidepressants and decided not to, is that something you would have recorded?
Not necessarily.
Dr. Galapathy, who saw him later,
Is that an independent?
an independent doctor, says that in her view, antidepressants should have been prescribed here. Do you have any comment on that?
I think different doctors have different clinical decision making, and there's different experiences. I don't know if Dr. Galapathy, did you say, is actually has experience working in any kind of secure setting. I don't know that experience, so she's entitled to her opinion by all means. We respect our fellow clinicians.
You didn't open an ACDT as a result of this consultation. Was there a reason why not?
I suspect he wouldn't have a need for constant observations. He was under the mental health team that he'd self-referred recently to. That's what you said, right?
Yes, but an ACDT doesn't have to be constant observations, does it?
No, it doesn't have to be. But I'm saying there was no need. I didn't feel at that point that it was required, just because there was no acute issue that needed to be managed.
On this occasion, you do also do a Rule 35(3) report as a result of his disclosures that noted there about abuse he suffered in Somalia. Could we just see on screen, please, CJS 30848? And it's at page 1. Sorry, I scroll down. This, and sorry, page 3, please. And page 4, please, sorry. You record there, he does not have any scars relating to the account, but this is consistent with the account. He describes a traumatic event. I'm unable to comment on prolonged detention effects or credibility of account. If we have HOM 4013, please, on screen. That was the assessment you made under Rule 35(3). The Home Office then responded, and on page 1, say, he, that's you, the doctor, gave no assessment as to the impact of ongoing detention on you. And at page 3, please. It says in the third small paragraph in the second line, although it is accepted that you are an adult at risk, the doctor has not indicated that a period of detention is likely to worsen your symptoms. You'd agree from the Rule 35 report that you hadn't commented on the impact of ongoing detention.
I think I commented that it would be difficult to comment on the impact of ongoing detention.
And the Home Office is here relying on the fact that you haven't indicated that a period of detention is likely to worsen your symptoms as a reason for maintaining his detention. Were you aware that they were making that kind of reliance upon you not commenting upon the impact of detention on a detainee?
I think we would, in those reports, we would generally comment if we felt that there was a need, as in we felt very strongly a threshold had been met internally, if you will, that we felt that detention. So by not commenting on it,
The form directs you to comment, though, doesn't it?
Yeah, but if you have to be able to justify your particular comment. So if you feel from the information in front of you that you can't comment, we're stuck as GPs making a black and white answer when actually most things are grey, and it's likelihood and injuriously. So I don't. The answer to your question is, did I know the Home Office was making decisions? I would assume they'd make decisions on the information we provide to them, but I didn't necessarily know the absence of writing something. That's what you asked would imply. But it wouldn't be if I felt very strongly that I was one way or the other. Then I would implicitly say that.
Given what you had documented, wasn't it clear that the detention was at least likely to injuriously affect his health? He was likely to deteriorate in detention, wasn't he?
And I think that's the difficulty. Is likely. I don't think if I felt it was likely, I would have said so.
You didn't consider a Rule 35(1) report, even though he had self-harmed. Why not?
I would assume it's. Well, I haven't done one, so I don't know why I haven't done one. I assume that I'd commented during that report, as I mentioned earlier, that we would put all the information into the Part 3 of the Rule 35(3), Section 6, which means it would be duplication. That was most probably the reason.
Did you consider him talking about previous suicide attempts as being relevant to his current risk?
I think it's a factor. I don't think someone having had suicide risks in other contexts without knowing the context necessarily implies that they are a suicide risk now. Like once you've done it, you could always do it.
But self-harm in the past and suicide attempts in the past are a risk factor for suicidal intention.
Sorry, but it is whether it's likely, and I think you can always make the case that any kind of history of mental health could mean that they are likely, and unless that is well defined to the clinician, essentially what the outcome will be that every clinician writes with any vulnerability that they could get worse, and then that's not a very helpful document for the Home Office. I'm not suggesting we do things that are helpful, but the idea is communication of vulnerability, and if we assume.
But wasn't he vulnerable because he had previously self-harmed and previously attempted suicide?
But vulnerable, is he likely to do it? That's the difficulty. It's a risk assessment, and there's no clear guidance as to how risk. You can say you're more at risk if this, but actually, I'm not sure how useful that is for the person completing the document, and that's what doctors were often having to do is likely. It's easy to say when they are getting worse in that respect because you can see that deterioration and you can focus on detention being the reason. But it's not so easy if you're just accumulating risks, because you could have a risk of my risk of ischemic heart disease is a percentage risk. So I think this is the problem is what is considered likely.
I see. Chair, that may be a good moment for a lunch break.
Thank you very much. We will still aim to return at 2 o'clock.
Yes,
we have
please.
a lot to get through this afternoon. Thank you, Dr. Israeli. Thank you.